So we are live now.
Good afternoon, everyone, and once again, welcome for Metasearch Obecon, the third day session. 2 days went very well, and everyone enjoyed the presentation from various endocrinologists, internationally reputed faculties. And today is the day of topics on bariatric surgery. First of all, let me thank entire OSCE executive committee members, entire IPSO executive board and committee members for endorsing this conference and supporting us for this. Today we have very interesting topics, may not be actually technical or surgical, but different thought processes about different procedures. Almost we have included standard procedures, endoscopic procedures, novel procedures, and we are eager to listen to all foreign faculties. To begin with, we have first of all a renowned diabetologist and endocrinologist, Dr. Bansi Sabu, who is the founder of Diabetes Care, Chief Diabetologist and Chairman, Diabetes Care and Hormone Clinic at Ahmedabad, President of Aero, who has made Aero grow a lot, Honorary Secretary of Diabetes in Asia Group, Indian Academy of Diabetes, Managing Editor, Sariko's International Textbook of Diabetes, who launched the project Diabetes Free India 2030, acknowledged by Honorable President of India, Shri Pranab Mukherjee, founder of NGO Diabetes Care India, India Suite Registry Project, advisory board member of JAPI, Journal of Diabetology, JOMR, expert of RSSDI guidelines for management of diabetes, ATTD, CGM guidelines, SPED guidelines for pediatric diabetes, more than 115 publications in index journals, and a very popular, very famous, and a very friendly and very supportive clinician and President RSSDI Research Society for Study of Diabetes in India presently. Let us listen to Dr. Bansi Sabu, please.
So first of all, thanks Dr. Shashank for giving me an opportunity to give a talk on a very important topic on a medical and surgical reversal of type 2 diabetes. I'll be discussing long-term outcomes and comparison between surgical and medical reversal. I don't have any conflict of interest for this talk. No financial disclosure is made for this particular talk. First very important thing is type 2 diabetes is irreversible. Before a few years, we were knowing that type 2 diabetes is irreversible. It is progressive with beta cell damage. But restoration of normal glucose metabolism within days after bariatric surgery in the majority of people with type 2 diabetes actually disproves this concept. Reversal refers to the change in the direction of underlying process. And to say that a type 2 diabetes is a reverse is a statement at that point in time. It implies no future prediction. Why so much hype had occurred after this particular paper? Because medically we could reverse the diabetes, and this was one of the direct trial, open label cluster, double-blind cluster randomized trial, which was published and which has talked about a diabetes can be reversed. But it was not only a paper. Rather, before this, 1 year, there was a paper in Journal of Clinical Endocrinology and Metabolism, and they had also talked about a short course of intensive lifestyle and a drug therapy achieves on treatment normoglycemia, and it promotes sustained weight loss. And this may achieve a prolonged drug-free diabetes remission, and it strongly supports ongoing study of novel medical design targeting remission. There is an Indian data also from Pune only, from Anjali Bhatt and Unni Krishnan. They had talked about a small proof of concept that a person with who is taking 2200 kilocalorie per day, if he is being programmed in a diet of 1000 kilocalorie per day with a baseline A1C of 9, he could have almost diabetes reversal. With a A1C, he could achieve almost 6.2. But the number of persons in this particular study was less. It was 12, and it was only a 3-month intervention. But it had proved the concept that even with a low calorie diet, it can happen and reversal is possible. We know there are two major hallmark features of type 2 diabetes. First is a first phase of insulin secretion goes away, and there is a insulin. Important features of a type 2 diabetes, and if person reverse mean if person can get again the first phase of insulin secretion with significant reduction in insulin resistance, then you can say a type 2 diabetes is actually reversed. The first time in 2011, Dr. Roy Teller had talked about the reversal of type 2 diabetes, a concept he had put. And what was the concept is a twin cycle hypothesis. Primarily, why somebody is developing type 2 diabetes? It is a chronically positive calorie balance. One is eating more and more. At the liver, this increase in liver fat, increase in VLDL triglyceride, increase in islet cell triglyceride, and second cycle of pancreas starts, which is actually decreased insulin response to ingested glucose. And these two cycles, actually, once again the pancreas cycle will increase the postprandial glucose level, increasing plasma glucose level will increase the basal insulin secretion level. Again, there is a higher insulin resistance at liver. Again, there is a more liver fat, more islet cell triglyceride, and again the pancreas will have decreasing insulin response to ingested glucose. So if the prime driver of this chronic excess calorie intake is removed, the direction of this cycle could be reversed, and that is how a type 2 diabetes can be reversed. It can have U-turn, and this was a work from Dr. Roy Teller. But the major question was whether this remission is possible in a clinical practice, and that's how he designed his trial in a primary care practice. And he tried to understand that with a low calorie diet, how long a dietary weight management can generate remission of type 2 diabetes. Direct trial had shown an open label cluster randomized trial at 49 primary care practices. There were patients who were already having less than 6 years of diabetes. They were BMI of 27 to 45, withdrawal of all anti-diabetic and anti-hypertensive therapy. They were given a very low calorie diet, and food was given them, 50% of them is carbohydrate, 35% total fat, and 15% of them were on protein. The direct study after 1 year had talked about that there are almost 17% in intervention arm and 2% in control arm had a weight loss of at least 15 kg. So the direct study had talked that low calorie diet can reduce the weight by 15 kg in 1 year data. With 36%, means almost 1/3 of them were having a control remission. So I mean 100% in control arm and 1/3 of them had a remission for up to 1 year. Now, the data is very interesting for 2 years. And what was that data of after 2 years? That in 1 year, as I told you, it was 24% who had remission, while here it was those who had 15% weight loss, 15 kg, while at 11% after 2 years, diabetes remission was in 46%, while it was 1/3, it is 36% after 2 years. So the interpretation of direct program with the sustained remission at 24 months for more than 1/3 of people with type 2 diabetes, and sustained remission was linked to the extent of sustained weight loss. The conclusion of direct study was that type 2 diabetes with a less than 6 years of duration remission is possible with subjects whose BMI is more than 25. They should not be on insulin and they are willing or motivated to follow a low calorie diet. But present study, when it is extended up to 2 years, it had shown that as it is extended for more years of this program, there are less and less number of persons are actually getting remission, and we get many of them are not getting the remission also. But direct had shown a bright future with people with type 2 diabetes if they are given a low calorie diet or a total diet replacement is done. But in a real practice, how many of our patients on a medical management actually going for reversal? Because if you see, you can count only few of them. Some of them are highly motivated. They can go for a very low calorie diet. They can go for a formula diet for a few months to few weeks, and they can have remission, or they can have a few molecules which can be continued, and many of the insulin and other things can be stopped for these particular patients. So actually reversal is a fact. This is proved by many clinical trials, many papers, but it is fiction in a clinical trial in a real world data, because less number of persons are actually going for a reversal of diabetes. And this possibility of reversal of diabetes in a country like India, where we are consuming high carbohydrate diet, is again more difficult, because after the 3 months of very low calorie diet, these persons, when they were given the normal diet, they were supposed to take less than 50% of their diet by carbohydrate, which is very, very difficult in Indian situation, where we are eating almost 75% of our diet is consumed is only carbohydrate. So there is definitive limitation of medical treatment. But there is a possibility of metabolic surgery. It does not mean that I am promoting the metabolic surgery, but we have to understand that medical treatment has got its limitation. Only highly motivated patients can go for that. But the same thing is the limitation for surgical treatment also. We have to motivate the patient, but those who are going for metabolic surgery, let us see what the results are. There is a rapid improvement of diabetes after this metabolic surgery. You can see the patient who was taking 90 units of insulin. Within days after that, within 12 days, actually patient was on a zero amount of insulin. And that's what rapid improvement of diabetes. I mean, one side you have a patient who is taking high amount of insulin, and we had seen that patients who are on insulin, rather than the second day or third day, many of our patients were stopping their insulin also. The medical outcome of a gastric bypass is almost improving patients in diabetes mellitus, or 84% of them are actually going of resolving the diabetes, which is not possible in a medical therapy. This is one of the paper which was published in a New England Journal of Medicine long back in 2014, which had compared intensive medical therapy versus the patients who are going for a gastric bypass or metabolic surgery. And it had shown that the patients who are on bariatric surgery, who are on metabolic surgery, there is a significant remission on reversal of diabetes, while those patients who are on medical therapy, most of them, they fail for that. Type 2 diabetes actually resolved or improved in 87% of the patients who are following bariatric surgery. This is one of the more paper which is published in American Journal of Medicine. And this is what the incretin effect. You know that with the patients who are actually without, with the very intensive control of diet, and those patients who are going for a bariatric surgery, or particularly the patients who are going for a RVGB, a gastric bypass surgery, you can see that there is a significant increase in insulin level, which happens only with the patients who are going for the bariatric surgery, which does not happen with the diet therapy. So the bottom line, 100% diabetes remission can be done by 3 months. Even in 1 month in many of our patients which we see, the weight loss of 1/5 of total body weight is actually decreased in first month only. And they have better than expected for severe obesity, that 84% of the diabetes get remission because of their 1/3 of body weight which got lost. The Asian Indians have high increased diabetes risk at lower BMI. And now this is very important question, because we are not that all the patients who are having the BMI of more than 28 or 30 or 35, which is the actual indication to start, giving them a choice of metabolic surgery. That is what, more than 30. But we are developing diabetes even at 24, even at 25, even at 23. So what to do with these patients? Should we put them on a bariatric surgery, or should we they continue with the medical therapy only? So those who are obese, overweight, where we can think of either they are highly motivated for low calorie diet, they can be given a very low calorie diet, and then it can be continued for next 2 years. If they can reduce their weight by 20% with this low calorie diet, the diabetes can be reversed in many of them. And those who agree for the bariatric surgery, there is definitely results of bariatric surgery. But the long-term results of surgery itself is, we don't know after 5 years or after 3 years, because there are data of showing which is after 3 years or 5 years are there. But there is always an apprehension of weight regain. There is always an apprehension of relapse of diabetes also. Nutritional care is lifelong, and surgery, even though it is keyhole surgery, but surgery is surgery. And the complication of surgery are also known with the obese person also. So these are some of the limitations which we are seeing with a person who is going for a metabolic surgery. But at present, bariatric surgery is the only scientifically proven long-term solution. If we are talking of long-term solution for morbid obesity and their complication related disorder, I think probably bariatric surgery is the only scientifically proven. While we get better medication alternatives which are available. Now we are having GLP-1, GIP, we have dual antagonists, and they are really effective in some of the patients. Now, recently we have one semaglutide data which had shown even weight loss of up to 18 kg. It means almost like 15 to 20% weight reduction was there with this GLP-1 also. So till that it comes in a commercially available for our Indian patients, bariatric surgery is only scientifically proven long-term solution for the patients who are either morbidly obese, who are BMI having more than 35, or with 30 with comorbidity, or with the patients who have obesity, and which is, I mean, morbid obesity with diabetes, and the routine therapy also. To conclude my talk, type 2 diabetes is a condition that develops in people who consume more calories than they require over a long period of time. More fat in body can lead to excess liver and pancreatic fat and subsequent loss of plasma glucose control. The traditional concept of type 2 diabetes being a irreversible and a progressive disease has been challenged. Evidence exists that type 2 diabetes reversal is achievable either using bariatric surgery or very low calorie diet and a significant carbohydrate restriction, which has to be long term. As physician, we must grasp this paradigm shift in our understanding of type 2 diabetes for the benefits of our patients, that reversal of type 2 diabetes is possible. We can think of metabolic surgery more often for our obese patients to get diabetes remission. With this, I once again thank you, Dr. Shashank Shah, for giving me an opportunity, and thank you for recording this lecture. Thank you very much.
Thank you, Dr. Bansi. Very well covered. Hardik, can I have my video? Yes. Is Dr. Bansi also live, Hardik?
No, sir.
No.
No.
Okay, anyway. Hi, Kamal. Welcome here. Thank you for joining. So we had a first presentation from Dr. Bansi Sabu, and who covered and compared medical and surgical reversal very well. So actually one more addition here, the surgical reversal has a part of medical reversal therapy hidden inside it. What was offered in the direct trial, very low calorie diet, is very easy and feasible after bariatric surgery. The additional benefit is the long-term maintenance of weight loss happens from various neuroendocrine hormonal actions and secreted by various parts of GI tract, and that is how it is easier to sustain surgical reversal of diabetes for a longer period than medical reversal. However, with the availability of newer medications and newer molecules, probably results of even medical reversal as well as surgical reversal could be prolonged for much longer than what we are expecting as on today. Relapse happens both in medical as well as surgical treatments, and that is because genetics and body's metabolism does try to compensate ever. However, even after a relapse, if the patient is easy to control, better controlled, and his comorbidities are much less than maybe at the beginning of therapy, it is still a benefit. So relapse is not something which is negative. Relapse happens for every disease that we come across. I must thank Dr. Bansi Sabu for his excellent presentation, and we will go to the next presentation. We have Dr. Kamal Mahawar here. I believe Dr. Ratlaj is on a flight. However, he had sent his video from a YouTube. Dr. Ratlaj is the inventor, and he sent his YouTube video, and we have Dr. Kamal Mahawar, who is live here. Thank you for joining us live from UK. He is going to talk about OAGB not for all. Who should be the ones who can undergo surgery like OAGB is what we would like to listen from Dr. Kamal Mahawar. I must tell you, a very good researcher, a very renowned surgeon, the consultant general and bariatric surgeon at Sunderland Royal Hospital in north of England, a visiting professor. He is an associate editor of obesity surgery, annals of Royal College of Surgeons England, clinical obesity, and is on the editorial board of SWORD as well. He's a member of council of AHCBI and is associate director for the conference. He's also a council member for BOMS and chairs its patient safety committee. His first book, entitled The Ethical Doctor, was published by HarperCollins in 2016, and he had several papers published on OAGB and various other metabolic surgery aspects, and very helping to the entire Obesity Surgery Society of India. Dr. Kamal, please. Can you start his presentation, Hardik?
So, just Shashank, thank you. And can I share my screen, Shashank?
Can we have him share his screen? He will just permit you to share your slides.
Sir has
That's
permission
fine.
to share.
I mean, so what? Do I have the permission now?
Yes, sir.
Okay. All right. Okay, I think it's not finding my slides.
Take your time. Don't mind. Have you opened your presentation?
Yeah. I think what is happening is they are asking permission to record it, and my computer is then taking it. Can we not record it, and maybe then it will be easier for me to open it because it's open on my computer.
Sir, minimize your Zoom screen, then open your presentation.
Okay, so I will open. I've minimized my Zoom screen.
Yes, and then
the presentation.
Open your presentation.
The presentation is now open.
Yes.
It's
Go
on
to the.
play. Can you
Go,
see it?
go, no. Go to the Zoom. Go to the Zoom.
Okay. Yeah, all right. I'm going to
And
Zoom
now
now.
click on the share screen button.
All right, just 1 second.
In the dialog box, you can see your screen, your PPT screen. After the click on the share screen.
But editing is not difficult.
Right, I'll try again. Share screen.
Yes.
It's not what. Can I send you my slides very quickly?
Yes, sir. Yes.
Yeah, and then hopefully you can, just,
go on. Yes.
play them.
Perfect.
Okay. And while the slides are coming, I can start talking anyway because. Okay. I don't know how big the file is.
We just heard in IPSO, and I want everyone to hear that presentation, balancing the indications for OAGB.
Yeah. So.
Hardik, you can share his slide if that is easy, and then.
Yeah, I think it's not Hardik's fault, Shashank. It's my fault because I could not record it for him. So look, I have a solution, Shashank. I won't be able to share slides, but I can see my slides and you can hear me.
Yes.
So can we talk about it and
yes, or you can just email them to Hardik, and Hardik will simultaneously then upload your slides.
Okay.
Hardik, is that
Yes, sir. Email me. I share my screen from here.
Okay, the file is a bit too big, so I'm going to share that on a computer. Just give me 1 second. It will come. Sorry, we're holding everybody.
No problem.
Yeah, that's so quite.
Okay. So Hardik, it was over to you now. It should have come. It will come as a Google Drive.
Okay. Sir, also give me the access for the Google Drive.
Yeah. So
OAGB
no,
master has also
it
joined.
should come to you. Are you able to open it?
So just a second, I will check.
माझ्या फोन मध्ये प्रॉब्लेम.
तुम्ही कोणाकडे पाठवायचा?
Hi, Dr. Kamal.
Hi, Kalipak. We're struggling with the share screen thing. I'm going to try a different thing here now, so that might work. Shashank, I'm going to log out and log in with a different computer, so it might give me just give me 10 seconds. Please.
No worries. No
I
worries.
received your presentation. Just a second.
Thank you, Dr. Kula, Indian master
Unmute
in
sir.
OAGB.
Please unmute yourself.
You can unmute yourself, and he's now playing Dr. Rutledge's video. So we can run this video. He said he's little harsh. It's a YouTube video, but truth about OAGB, MGB. So Hardik, we can run this so that Dr. Kamal gets subtitled.
Yes, sir. Yes, sir. You can start, sir. If you want to present this slide, search slides, search introduction slide. If you want to present, sir, first.
Dr. Kula, is that right? That's the video he sent.
Whatever you say, I think we can start with the presentation. Everybody knows Rutledge.
Yeah.
And what do you say?
Yes,
If you want
he's an
to
inventor,
introduce, you can.
inventor of
Or should I
MGB.
introduce him?
Yes, he can also.
Hardik, you can start.
Right. So, good evening, everybody. First of all, congratulations, Dr. Shashank Shah and Mrs. Shah. Nice to see you after so long time. I need to introduce Professor Rutledge here. Am I audible?
Yes.
Hello.
Yes, yes, we can hear you. Dr. Rutledge, yes.
Right. Yes. So I'm here to introduce Dr. Rutledge. Basically, Dr. Rutledge started mini gastric bypass in 1997 in North Carolina when he was a trauma surgeon there. And he met with a patient who had a gunshot wound, and he had to make this kind of connection. And that is how he got an idea to do this mini gastric bypass. And we all know that eventually this procedure met with a lot of controversy. And at that time, Dr. Rutledge had two options. Number one was to continue with the general stream and continue with the Roux-en-Y and other surgeries. Number two, he selected this number two option, which even had to kind of, force him to stop his practice altogether for some time, because there was a lot of hue and cry, and eventually a legal body was there, to investigate his patients. They had to talk to his patients, how they are doing. And eventually he was back to practice and started his practice with mini gastric bypass there. And still the controversy went on, and he had private patients because the procedure was not recognized by sorry for the, I think there was something wrong with the connection. So now we all know that Dr. Rutledge, having gone through so much of controversy and hard work, and he opted to be out of practice for a long time, just because the reason that his own practice, his own patients, his own data was saying that the procedure is good, and he wanted to show the world that this procedure is really good. And now we all know, whole of India, all of us, and so many other surgeons in different countries, in different corners of the world. And even IFSO has recognized MGB, OAGB as a mainstream procedure. And in this, actually, Dr. Kamal Mahawar has got a big role in this as well. So we are not debating actually on some critical issue. The issue now is that whether or not mini gastric bypass, MGB, OAGB should be used on everybody. And Dr. Shashank Shah must be remembering like 10 years back when Dr. Rutledge was here in one of the national conferences. And whenever you would ask him, will you do it on a child? Will you do it on a 90 years old? He will say, yes, yes, yes. So now we are here. So Rutledge had to leave for US. And I am playing his video, which he recorded for this debate. I'll be sharing the screen now. So here we go. Dr. Kamal, are you there? This might be a little harsh. I told Rutledge to be gentle, but as we all know, this is his problem. When he starts talking, he cannot stop. But let me tell you, he's an honest man. So here we go.
Hello, this is Dr. Rutledge, and I've been invited to talk for about 15 minutes about when it is appropriate or reasonable to consider mini gastric bypass for different kinds of patients. And since it's a short little presentation, I'll go through that, and I'm going to switch the screen over right now. Okay, so now we're screening, we are sharing the screen. Let me show my mouse. Visible. Good, a few fine points. Ideal candidates for the MGB, and I can tell you the end of the presentation now, which is everyone is a good candidate for MGB, but not every surgeon is a good MGB surgeon. And so it might be a little controversy there. Reminders, MGB is simple, elegant, effective, durable. We now have over 20-year data. And as I'll emphasize later, you can talk to 20-year MGB patients on Facebook today. That is to say, between 10 and 20-year MGB patients are available for you to talk with who I've operated on more than 10, 15, or up to 23 years after their MGB on Facebook today. You can talk to them and ask them if they have problems or how they're doing. The MGB is very powerful, but also uniquely can be tailored to the patient, as we'll talk about today. It's reversible and revisable, and we find a large number of surgeons are unaware of this, or they do it poorly. And it is revisable in addition to being specifically reversible. So again, let me emphasize that you don't need to listen to me. Obviously, I'm biased about the MGB, as you'll see. But for example, you have a unique opportunity. You can talk to literally thousands of my patients who are 10, 15, or 20 years after their surgery on Facebook today. That is thousands of my personal cases. You can talk directly and ask them how their MGB is. Similarly, you can talk to sleeve patients. You can talk to Roux-en-Y patients. And the number of tragedies that you can run into there, I think personally, is overwhelming. But I invite you to confirm some of the things I say by talking directly to my patients and not necessarily taking my word for it. Again, more than 5,000 of my patients, MGB patients, not just of mine, but around the world, from Australia to Kazakhstan, from Africa to Europe to the United States and Canada. There are thousands of MGB patients online today. Go ask them how they're doing. And then my suggestion is to go and talk to sleeve patients. Just as an aside, I recently talked to a friend of mine in Dubai, and she says her highest rate of cases that she does per day is now sleeve failures. So you don't need to go back very far to find out the failures of lap bands and sleeves. And we ask that you consider talking to my patients about their 10 to 20-year weight loss. Whether or not you find any patients of mine who have low protein, ask them about viral reflux and other problems. I think you'll find the MGB in well-trained hands is quite a good operation. And so this is the paradox which I want to focus on. Because I only have 15 minutes, I can just barely touch on some of these topics. But what you can see now in hundreds of patients and hundreds of publications on the MGB that is increasing at an exponential rate in PubMed is superb results in the hands of some surgeons. On the other hand, complications, reflux, gastritis, bile, malnutrition, diarrhea, ulcers, and death are in the hands of, well, dare I say it, surgeons not trained by me. So my bias is that there is a paradox. There are surgeons who are worried, frightened, have had complications. Most of them who I have seen report this have not had education or training with me. Again, let's give an example. Well-trained surgeons reporting thousands of patients, Coular, Mario Musella, and many others are examples. Complications, reflux, gastritis, malnutrition, diarrhea, death in hands. And just as an example, think of the Y Omega trial. Again, because time is limited, I don't have the opportunity to go through all of these, but there is quite a paradox that you can see in the literature. Again, just a reminder, the MGB is an operative procedure which frequently shows misunderstanding and mismanagement by surgeons. And because the surgeons and nutritionists don't understand it, even now 20 years later, there's widespread misunderstanding and harm because of lack of knowledge. Standard general surgery is all that it is: antrectomy, gastrojejunostomy, and a collis gastroplasty. It's not an obstructive. It's not a sleeve. It doesn't need a band. It doesn't need a tight pouch. It doesn't need an obstruction. And the anticolic Billroth 2 is tailored to the patient. Again, these are simple components, and when people violate them, they often end up with complications and problems. And that's bearing on our topic today. So what patients are ideal candidates for the MGB? Well, in short, the MGB is good for everyone. The usual bariatric patient with or without diabetes, the super obese and the super obese, patients with GERD, and that's widely misunderstood, difficult patients who might have psychiatric or other problems because it's reversible and revisable. It's good for children because, again, if they do show any problems with the operation, it's reversible within 20 minutes. It's good in the elderly because it allows patients like the elderly to eat a more normal diet, and it interferes with eating the pathologic foods like sugars and fats. It's good for alcoholics because alcoholics, if they violate the principle of abstinence post-op, that allows us to reverse it as long as we educate the family and the patient that should they have inability to control their alcohol intake, we can reverse it quickly. It's also good in borderline patients, psychiatric patients, Prader-Willi patients, as it's been shown in publications, because again, in cases where it's not successful, it is revisable in less time than it takes to get a haircut. In the future, we see that it's useful in non-obese diabetics, non-obese metabolic syndrome, non-obese hypertension, arteriosclerotic cardiovascular disease, peripheral vascular disease, liver disease such as NASH, cerebrovascular disease, and more. So all can be good patients. The issue is the quality of the surgeon, the skill of the surgeon, and the preparation of the patients. I'll take a moment and remind you of the history of the MGB. Basically, I was a trauma surgeon for 20 years, and now 23 years I've been a surgeon. In 1997, an illegal drug dealer shot 6 times in the abdomen, and 9 o'clock at night in September 1997, I took him to the operating room and found bullet wounds to the stomach and the tail of the pancreas and multiple loops of small bowel. So with these injuries, I did a distal gastrectomy, a distal pancreatectomy, and splenectomy, repaired numerous loops of small bowel. And I reconstructed him with what is now known as the mini gastric bypass. At the time, of course, it's a Billroth 2 gastrojejunostomy after an antrectomy. 20 years later, surgeons still can't figure this out. Somehow they still think it's some kind of unusual operation when it's done routinely and has been done routinely for 140 years. The MGB is not a Roux-en-Y with one less anastomosis. And when people misunderstand this, they harm patients. The Billroth 2 is a good operation. General surgeons know this, and they use the Billroth 2 every day. Many bariatric surgeons are uninformed, and they fear the Billroth 2. Apropos this discussion, this demonstrates the misunderstanding. So uninformed, fear the Bill Roth 2, an uninformed and untrained surgeon should not do the MGB under any circumstances for any patient. That's as simple as that. Without the adequate training and understanding of the operation, don't do any MGBs, period. You're not the surgeon. We see this all the time. We see the short pouch. We see misunderstandings about how simple, elegant, effective the operation is. And so here, briefly, let's remind you of the operation. 4 ports, 5 ports, dissection of the lesser curvature, stapling in a right angle to the side, staying wide from the port and from the bougie. We stay away from the EG junction and we make a cobra head at the tip. And again, we see widespread misunderstanding of this approach. Gastrotomy, enterotomy, gastrojejunectomy, and surgery is done often in 20 to 40 minutes. And patients can frequently go home the same day. We see this misunderstanding every day. Well-informed general surgeons, as I say, routinely use the Bill Roth 2. Uninformed bariatric surgeons, apropos our discussion today, fear the Bill Roth 2 and misunderstand it. Some of the key components that are widely misunderstood is that the pouch is not a sleeve, it's not a lap band, it's not a Roux-en-Y pouch, it's a collis gastroplasty. That's a non-obstructive gastric tube, it's not a sleeve or Roux-en-Y, and this can lead to problems post-op and misunderstanding. Antrectomy in Bill Roth 2 is non-obstructive gastrojejunectomy, and we see this violated routinely. And it's not the short Roux-en-Y and not the long BPD. So knowledge equals technique. If you don't understand the mechanism of action and the anatomy, then what we find is you don't know how to do the surgery and then you harm patients. So the MGB is not an old Mason loop. The MGB is not like the Roux-en-Y or the sleeve. The MGB is not primarily malabsorptive, widespread misunderstanding. You'll see confused surgeons say this all the time, and it's very disappointing and misleading. The MGB is not like the jejunal ileal bypass. It's not a massive gut bypass. We see misunderstanding of the mechanism of the action of the MGB. It is restriction without obstruction. It's a post-gastrectomy syndrome, which you can look up and we've known about for almost 100 years. It is good dumping versus bad dumping, and it's not a band or a sleeve. The MGB is easy if you know what you're doing. It is a disaster and deadly in the wrong hands, and we've seen that, for example. All the details for doing a good MGB, if you don't understand the mechanism of action and the anatomy, that is knowledge, then you will not know how to do the operation technique. MGB surgical technique, we've gone over, and obviously I can't teach all of these things in this 15-minute presentation. But again, what we tried to do is give you some background. We have thousands of my patients that are 10 to 20 years out. You can talk directly with them, see if they are having trouble. The new MGB is available for all kinds of patients, and those people who don't understand it should not use it. Nutritionists need to learn how to use it. And so what we say, check out Dr. Rutledge's results, and I was happy to be here today. I'm sorry that I can't be there in person. I understand Dr. Kular will do a yeoman's job of trying to be more polite than I have been in my presentation, but I hope you'll wish me well as I return to my home in America. Thank you all very much.
Very well presented. Very good presentation. I believe now the understanding of MGB is much better. We wanted to listen to Dr. Rutledge. His entire presentation probably was MGB for all, and he tried to explain how he believes whether it is for all. And then we will have Dr. Kamal Mahawar, who has done a lot of research and publications and worked with Dr. Rutledge and Kular as well. So we will have his presentation get started. I must tell you, Sergio Santoro and all our foreign faculties, Oreo Di Paula, everyone is online. I'm more than happy to see all of them live. Dr. Kamal, please.
Thank you, Shashank, and thank you to the team, Harshit and everybody, and all the esteemed panelists. Good afternoon, good evening, good day, wherever you are. My name is Kamal Mahawar. I'm a consultant surgeon at South Tyneside and Sunderland NHS Trust in northeast of England, and I'm a visiting professor at the local university. Dr. Shah has given me a huge task of talking about which procedure is when an anastomosis gastric bypass, for example, is it suitable for all patients or not? And that's a very philosophical topic, and it is always a hard act to follow. Dr. Rutledge, who is not only a great surgeon but also a great speaker. We have had some differences on minor issues, but overall, I respect him from the bottom of my heart, and that he knows very well as well. So I'm going to just move to my next slide. This is where I work. This is our hospital. You can see the front of the hospital and the outpatient wing in the lower picture. It's in northeast of England. In terms of my disclosures on my practice, most of my practice is primary divisional surgery, and it used to be mostly Roux-en-Y gastric bypass. And over the years, it is now mostly one anastomosis gastric bypass with 20% Roux-en-Y, 20% sleeves, and 10% of overall practice is divisional. I have received some honoraria from various companies and various NHS trusts for mentoring and educational activities in the UK. Now, before we talk about the surgical treatment, and I was listening to, I think, probably an endocrinologist when I joined in, and they were talking about the same thing, you know, what is better, medical, surgical? Let's understand one thing, and we have learned this from various other medical disciplines. Patients don't make the distinction of medical, surgical, or different procedures. Patients are patients who've got diseases and they want treatment. For them, these distinctions of medical and surgical are artificial. For them, the distinctions of different procedures are also artificial. So I would like I've spent some time thinking about the issues that Dr. Shah posed me. And that is the reason I had problems with the slide, because I couldn't send him the slides earlier, which was the requirements. But anyway, so let's understand what is the spectrum of disease before we can understand the spectrum of treatment. We know that obesity is classified by the WHO. This is the classification in front of you. But majority of my patients are BMI more than 40, and they are all classed in one category. Now, I don't know if that is reasonable, but to me, it appears as if it is including a very heterogeneous group of patients that probably should not belong in one category. So I think we are not able to identify our patient's disease properly. You know that others have attempted to classify obesity. This is Professor Arya Sharma's attempt. We know from Canada he has done lots of work. His Edmonton staging system is widely cited, but not practiced. And you can see why, because it is so complex. I have tried to give you a chart here. Nobody in the world that I know uses this system of classification of obesity routinely in their clinical practice because it is not easy to use. Look at this slide here as well. This is the same group, and you have to take into account the medical, the mental, functional. It gets rid of the BMI altogether, which is the only number that we use mostly in our practice these days. And it's not being used. And the reason it's not being used is because it's too complex and it's probably not representative of the patient's disease as well. On the other hand, we also treat patients with diabetes. There, I think we've done a little bit better in terms of classifying the disease, because we have got impaired glucose tolerance, like pre-diabetes, and we have oral tablets, and we have injectables, that we have insulin, and we have a very good marker in the form of HbA1c and sugar levels to quantify the disease. So there, and the duration of disease as well, we have done very, very well. Duration of exposure is probably as important as in diabetes, because we know in diabetes that if you're exposed for a longer period to the disease, then you're more likely to have complications. But when it comes to overweight and obesity, we don't talk about duration of exposure. When we talk about weight regain after 10 years after any surgery, we forget that patient may have had 10 years of less obesity exposure, and that is very important as well. So when we talk about which procedure is suitable for all, I think there are some important considerations to think about. And I have listed them here in terms of spectrum of surgical efficacy. So if we were just to purely to focus on the efficacy of the operation, this is evidence-based. This is not just my opinion. I have listed them out in the order of increasing efficacy from gastric band, which I put in red because nobody would do gastric bands these days. I haven't done a gastric band since 2011. And then sleeve, and then Roux-en-Y, and OEGB, and CDS, and BPDDS. This is all evidence-based. I can cite papers after papers saying that the efficacy increases in this order. This is one data from systematic review. You can see that band, bypass, and PPD increasing efficacy. This is our own systematic review comparing 5-year results of sleeve gastrectomy on Roux-en-Y gastric bypass. At 5 years, Roux-en-Y gastric bypass has a higher excess weight loss, no doubt about it. In terms of diabetes, because these trials were not powered to evaluate diabetes, there was a tendency to favor Roux-en-Y gastric bypass at 5 years, but it was not statistically significant, simply because the numbers were too small in those studies that were in the meta-analysis. There were 5 of them. When it comes to risks, sleeve gastrectomy has got probably half the risks of Roux-en-Y gastric bypass. This is the MBS equipped data, half the mortality, 0.1% as opposed to 0.2%. So 1 out of 1,000 in sleeve as opposed to 1 in 500 with Roux-en-Y gastric bypass. Significant difference there. This is the same, if you look at more statistically relevant results, odds ratio of dying with Roux-en-Y gastric bypass, 1.64. Having a complication, 2. So that means, you're twice as likely to have a complication within 30 days after bypass compared to sleeve gastrectomy. So what we're seeing there, and again, because of the time, I have not cited studies after studies, so you'll have to take my word for it, that there's also a spectrum of surgical risk, which means that BPD-DS is the riskiest, followed by CDS, followed by Roux-en-Y gastric bypass and OAGB. Here you may disagree, depending on which trial you quote. We know from Lee's trial from 2005 that OAGB had lower complication rate. We know from Omega trial that OAGB had a lower 30-day complication rate. In fact, half the 30-day operation in Omega trial as well. But Omega trialists used a 200 centimeter limb, so their long-term nutritional complication rates were higher with the OAGB. That's why I have put down OAGB 150, which I'm convinced both in short term and long term will have a lower complication rate than Roux-en-Y gastric bypass. Sleeve gastrectomy is probably still safer, and gastric bands are still safer, but they don't work. So I put them in red. And I've also put BPD-DS and CDS in red because I think their complication rates are simply too high for primary bariatric surgery. When you're trying to understand the disease, there are some cutoffs that people have examined. So these are not my studies, and there are many studies that I can quote on these topics, but I've chosen 1 or 2. So studies are suggesting now that sleeve gastrectomy is probably not a very good operation for long-term durable outcomes or giving satisfaction to patients if the patient's BMI crosses 40 in this study, 45 in another study. So generally what people are saying is that BMI 45 plus, if you go, then sleeve gastrectomy doesn't tend to give, as a standalone procedure, very good results. And this many surgeons have reproduced. We have seen in our own practice, we evaluated our 5-year data, and we found that patients with less than 45 BMI preoperatively, they were quite happy with sleeve gastrectomy, whereas more than that, they weren't happy. So what is happening there? So what, again, I would like to explore these cutoffs more with you, but we need to understand that when we treat patients, there are 3 important considerations for us. First is the body mass index, because that is very widely used. And I know it's not perfect, but it is very important. What is the cutoff which is important at BMI level? We have traditionally thought of BMI 50 as an important cutoff, but I think that cutoff may be 45. We have to think about that. When it comes to diabetes, maybe the important cutoff is requirement of injectable diabetic medications or insulin. That is an important cutoff. And when it comes to reflux disease, contrary to the popular belief of hiatus hernia being an important determinant, I don't think so. In fact, we've got studies from our own center showing that it is not the case. Whereas preoperative medication use or PPI use on a frequent or daily basis, that is an important consideration. So these are the important considerations that we have found in our own practice. They're all evidence-based as well. So I can prove some, I can show you some data if you give me time, or if you want to talk to me later. So on the basis of this, my hunch is that because sleeve gastrectomy is very safe and it offers excellent outcomes in terms of weight loss, especially for patients with a lower burden of the obesity and diabetes, I think for BMI less than 45, maybe 40 in some cases, and certainly patients with diabetes on oral hypoglycemic agents, tablets, it's okay. But I would prefer to avoid it in patients who are requiring frequent medications or daily medications for GORD, or have esophagitis, or have Barrett's esophagus, or if they're requiring insulin or injectables for diabetes, or if they have BMI of 45. So that's where I would personally recommend sleeve. So I do not think OAGB is for all, not in my opinion anyway. Where would I recommend OAGB? OAGB is a gastric bypass procedure. it does have all the implications of a gastric bypass in the long term, I mean, and probably more than the Roux-en-Y gastric bypass, because there is no ruling where lots of absorption does take place. And my personal bias is that anybody with a BMI of more than 45 or type 2 diabetes on injectable medications or insulin should probably undergo an OAGB. Whereas I would prefer to avoid it in patients who are requiring frequent medications or PPI for GORD, because we have seen a higher rate of conversion in our own unit to Roux-en-Y configuration in longer term in these patients. I'm not mentioning hiatus hernia because hiatus hernia doesn't seem to be resulting in that. Roux-en-Y gastric bypass, I think it is the most complex of the three and probably most complication prone of the three. I would reserve it for patients with significant GORD who are requiring frequent medications and or Barrett's esophagus. I would certainly avoid it in patients with BMI more than 50 because it becomes more complex and results in more problems. But it still has a role in my practice, which is increasingly becoming fewer and fewer. So with that, I'm able to conclude that obesity and diabetes are very heterogeneous diseases, if you like. Surgical treatment needs to be tailored to the patient, and we cannot have a one size fits all, whether it's medicine or surgery. I think we need to look at the patient. And in future, when better medications come, it will actually enhance our surgeries more because we'll be able to give our patients better results. And I think we need to now examine specific subsets of patients undergoing different procedures to compare the outcomes before we make radical claims about the efficacy of one procedure for all the patients. So that's in brief my thoughts, Dr. Shah. Thank you very much for asking me to come and talk to you all. And if there are any questions, I'll take them. Thank you.
Thank you, Kamal. You really balanced it very well, and even Dr. Rakhtar explained this part very well. We talked about weight loss, we talked about long-term diabetes remission, ease of surgery, safety. We are all only surgeons here. Another question which comes to my mind, do you ever face a challenge of malodorous stools or frequency of bowel movements, and do we need to give medications very frequently for that? You can give your experience, both of you. I wish Dr. Rakhtar also could give that. Is there a challenge? Sometimes does it hamper quality of life patient, especially those type who are in US and who wouldn't accept so much of frequency of bowel movements? Any comment on that?
Shang, are you talking to me or are you asking Dr. Rutledge?
Sorry,
Kular.
Dr. Kular, and
Kular, you go ahead first.
This is.
I think Kamal, you should answer this first. You know my answer.
All right. Okay, fine. So Shashank, I'll take it on. When initially we started OAGB in our unit in Sunderland, we were doing a biliopancreatic limb of 200 centimeters as routine, which was our practice until 2015 end. And in that cohort, we saw approximately 10% patients with frequent diarrhea. And also internationally, we conducted studies and I spoke to many colleagues, and it became very apparent to me that most patients who were requiring further surgery or interventions for protein calorie malnutrition after OAGB, they had a limb length of 250, 300, even longer. So, and on the back of our data, we concluded, we also looked at lots of studies from Roux-en-Y gastric bypass patients as well, that a BP limb of more than 150 is not required. And I say that because in Roux-en-Y, the BP limb is only 50 centimeters. And we know that the elementary limb does not give any weight loss or any metabolic outcomes. So why should we do it 4 times for OAGB? And because we could only go down a little bit and we had to support ourselves with data, so we went down to 150. And we have reversed 1 patient in our unit for malnutrition. But we've had a few who required loperamide. In the beginning, we were also doing colonoscopies for some of them for diarrhea because we didn't know what was happening for diarrhea. And we've got a roughly between 5 to 10% hypoalbuminemia rate in our unit. So my personal bias says, if you ask me, that the limb length could even be shortened further without compromising the efficacy of this operation much, because we have also conducted studies and shown that OAGB 150 is giving equivalent weight loss to OAGB 200. So my feeling is that it's a very low volume problem because we've done close to 700, 800 patients and we have reversed 1. But equally, it can be almost prevented to 0 if we pay attention to limb length. That's my thought on it.
So can I ask you, Kamal, with this 150 centimeters BP limb, what is the approximate incidence of diarrhea in your patients now?
So it is much lower than it used to be before collapse. We are going to study this specifically now. So my impression is that if we were seeing roughly between 5 to 10% before, now it's around 1%, 1 to 2%.
That's it. So that's what I
But
want.
we're going to study this.
Right. So in majority of my patients, believe me, they complain of constipation in the first 2 months because they're eating less. So if I do longer lengths, then obviously yes, the incidence of diarrhea goes up. So that's it. Right.
Yeah.
Thank you very much.
One more thing.
We are going to have the same. Yes, sorry. Yes, Kamal.
So one thing is that this variation in length in measurement also we need to understand, Shashank, there, and my view is that whatever we recommend to people, the recommendation should be able to absorb everybody's variation. So because if you say let's recommend 100, then if you range between 50 to 150 or 200, you'll still be in the safe region. But if you recommend 200 and if you end up measuring 300 or 400, then you are not in safe region. So my belief is that the recommendation should be able to absorb the errors or variations in measurement. Sorry, I overspoke there. Thank you.
Thank you. Why I'm getting this point is I'm going to talk about and ask every speaker change in bowel habits, whether it's after OAGB, transit bipartition, other interposition, or further procedures. And this is for better understanding to all those surgeons who are listening to us. So a very balanced information about OAGB. Thank you so much, Dr. Kamal and Dr. Kudar, and I would be very happy that you are with us for even the further sessions. Thank you so much.
Thank you, Dr. Shashank. Thank you, Kamal.
Yeah, I see Santoro is eager. We are just 2 minutes delayed. Hardik, can we have Dr. Sergio Santoro's presentation and
Yes.
slide? So, do we have Dr. Amar and Dr. Narwaria here? Is Dr. Amar?
Hi, Dr. Amar is here.
Yes, Amar. So,
Surendra Ugala here, Amar is there.
yes, Surendra is also here. So, both of them are here. I would request them to introduce Sergio, and we have his presentation started.
I'm not able to start my video. Shashank.
Yes, please.
Logging in. So I'm not able to start my video.
Okay, just give me a minute. Let me ask Hardik to call you. Thank you.
Hardik?
He will do that.
In the meanwhile, if we want to start our session, let me introduce Sergio Santoro or Amar. Do you want to go ahead?
Yeah, please go ahead, Director Suren. You know better. You are the senior one.
The inventor. For me, he's an inventor and a great surgeon. Yes, Suren.
So we are glad to have in this session, and I must say very well thought of subjects and topics selected by Shashank for this MetaSurge meeting. MetaSurge with a difference. Sergio Santoro has been a prolific surgeon in bariatric and metabolic field in Sao Paulo in Brazil. And I've had the pleasure of knowing him for many years, have seen him through the ages when he initially did present us with a little bit of a shock value with doing some very major resections of the small bowel, etc. But he went on progressing with his ideas, his thoughts about the GI tract, about nutrition, and he's been the pioneer of the transit bipartition operation. And I've seen a lot of his work, read a lot of his publications, seen him at meetings, and I know that people who I have trained for ileal interposition, like Alper from Istanbul, they have moved a bit from ileal interposition to transit bipartition. So this should be a very interesting subject where I have actually seen Alper. I know his reasons. So it would be good to see what Sergio thinks about transit bipartition, probably trying to replace ileal interposition, and then we have the pioneer of ileal interposition, Aureo De Paula, who's a close friend and a thinker surgeon, as I call him, to speak about ileal interposition not being replaced by transit bipartition. So Sergio, we'd love to hear what is the latest from your side. And firstly, do you believe that it will replace ileal interposition? Question number one.
Well, thank you very much. First, Dr. Shashank, for the nice invitation. Very honored by the invitation. Very honored to be with you all. And Surendra has been a good friend, and we are exchanging ideas over the years. And it has been a pleasure to exchange ideas with you. I think you have my presentation video, don't you?
In the meta search,
Hardik, can we start Dr. Sergio's presentation?
I want to thank all my friends from India, especially Dr. Shashank Shah, for this invitation.
Everybody, please stop your video, please.
It's an honor for me. I am going to talk about the transit bipartition or ileal transposition. I took part in the foundation of short bowel syndrome unit in the 90s. And there we observed that distal resections could be a tragedy, while some proximal resections could even cause some metabolic improvement. The gut hormones were being born at that time. We are starting to understand gut hormones, and we are starting to understand the small bowel as an endocrine organ. They indeed are in endocrine organs, but the proximal part is very different from the distal part of the small bowel. In the endocrine activity of the proximal gut, there is a lot of caution to avoid the hypoglycemia, because when you start a meal, you're going to secrete insulin, and there is not too much glucose in your blood because you're starting a meal, you're probably starving before. So in the proximal gut, there is secretion of GIP that provokes insulin and glucagon secretion, which provides gluconeogenesis, a production of glucose in the beginning of a meal with food in the proximal gut. This production is to feed the hungry cells with both insulin and glucose. So this activity does not block gastric emptying, does not cause satiety, does not end a meal, because we are very in the beginning of a meal. But the distal gut is very different. It gives us different hormones like oxyntomodulin, PYY, and GLP-1 that cause satiety, that increase insulin secretion, that block glucagon, that delays gastric emptying, and ends a meal. More recently, it was also understood that FGF19 is a very important hormone. It's not produced by endocrine cells in the intestine. It's produced by common enterocytes, by the mucosa. And it's very much involved in glycemic homeostasis and biliary acids production. And low FGF19 is a predictor of metabolic disease. We know that if we block the FXR, that it's the receptor that provokes the FGF19 production during the absorption of bile in the ileum, the metabolic results of surgery are very much damaged. So FGF19 is really important. So the distal gut that provides also FGF19, it's very efficient in lowering glycemia, in blocking glucagon secretion, and in stopping gastric emptying. It causes a strong satiety, and when properly stimulated, the distal gut ends a meal. In 2003, we proposed that refined modern diet that is too rapidly absorbed in the top caused a proximal hyperactivity and a distal hypoactivity. And we wanted to fix this. We did not understand restriction or malabsorption as the means that these things work. And observing the jejunal-ileal bypass done in the 60s, we could see that in spite of non-exclusion of the proximal gut, there was rapidly disappearance of diabetes. And this is old, this is not new. And later it was recognized that there was a big elevation of distal gut hormones because of the early exposition of the ileum to nutrients. Nutrients in the ileum make you feel and behave like being fed. So only ileal surgeries really provoke high levels of remission in diabetes. But exclusions, they were made for malabsorption, and we do not want malabsorption. Malabsorption is a disease. So we designed bipartitions, many types of bipartitions, but this final aspect was designed in 2003. But I would like to emphasize that only ileal surgeries, and there are many of them, can cause levels of remissions greater than 80%. So nutrients going straight to the ileum is fundamental to obtain potency in metabolic surgeries. What is our transit bipartition? Well, we bring the ileum on 206 or to 3 meters to the antrum, creating a 3 centimeters wide anastomosis in the antrum. Maybe we think of using a bigger one in the super obese. And the common channel we have been enhanced over this time because we understood that the presence of bile is important to obtain the best activity, the endocrine activity of our ileum. So we enhanced it with better outcomes. Typically, most of the food goes to the ileum, especially in the beginning of a meal. Just when the ileum is full, that food starts to go to the proximal gut. All limbs are alimentary, and we have an extended endoscopic access because we have access also to the ileum. This anastomosis drains the stomach. So the intragastric pressure that is high in a sleeve is utilized to push food into the ileum. But we treat this high pressure, avoiding fistula because we alleviate the pressure intragastric, and maybe probably reflux because we lower the intragastric pressure. The presence of the anastomosis fixes the stomach, avoiding coils. So in many ways, the gastroileal anastomosis improve the results of a sleeve gastrectomy. We have a large experience by now. There is no mortality in our team, and it became very, very low in other teams also. There are 0 fistulas in the last 11 years, and we have very high remissions of hypertension, of triglycerides, hypertriglyceridemia, and high cholesterol. There's also a very important remission. But most important of all, we constantly achieve more than 85% of remission in type 2 diabetes without a complete exclusion of the duodenum, like it was shown before with the jejunal-ileal bypass. Weight loss is also very important. So we achieve weight loss that is very similar to duodenal switch. Indeed, it was compared to the duodenal switch by Dr. Topar that came with that TB is obviously faster and a smaller hospital stay. And he obtained just a little bit less weight loss, but he utilized a very large bougie like he does in duodenal switches. And in TBs, we recommend a typical sleeve, not a very loose one. So we tribute this to this fact. And curiously, he obtained the same amount of diabetes remission in TB and duodenal switch with less complications. So it seems that TB is potent like a duodenal switch, but with many advantages. We have done a prospective randomized control with a small group of very severely diabetic patients to study the hormones. And we came with a very high elevation of GLP-1 and a modest decrease in GIP. But also a big elevation of FGF19, like I will show you later. And we obtained in the small group 99 out of 10 complete remissions, while in the Stampede at the same 2 years, they obtained a 6 out of 18, 33%. And the DSS study obtained a 35% also. So it seems that ileal surgeries are indeed superior. In this small group, we obtain a remission of hypertension in all of them, and withdrawal of statins in all of them also. Well, other people have studied the transit bipartition, obtained the same kind of numbers we did, like very good weight loss, 95% of excess weight loss, and 94% of diabetes remission. Another study obtaining 85% remission. Another study obtaining 88% of remission in diabetes. And there are even more optimistic studies. In this case, they have obtained 100% remissions in 50 patients with type 2 diabetes with a 1 anastomosis bipartition. There's another study with diabetes resolution in 92%. So I will try to answer your question. Interposition or bipartition? Simplicity means safety, and the bipartition is simple. But we don't do it because it's simple. We do it because it's better. It brings up the whole ileum, not a part of it. And FGF19 needs the absorption of bile to produce FGF19. There is no bile in the transposed part. So I think that it has to be shown that this is able to produce high levels of the FGF19, which is somehow not expected. We can have bile present in the whole ileum if you do a 1 anastomosis, but in most of it, if you do a bipartition with a very, very long common channel. And we have shown a great elevation of FGF19 in diabetic patients that have this level lows usually. We have shown a 5-fold increase in FGF19. And we observe that there is hypertrophy of the ileum. And it is indeed the mucosa that produces FGF. So a hypertrophy of the mucosa will lead to an enhancement of FGF19, but it's dependent on bile. Well, the bipartition also diminishes the intragastric pressure. It utilizes the intragastric pressure to push food into the ileum. While in the transposition, the pressure might be higher because the ileum is not so propulsive as the jejunum, and this segment cut in both sides is disconnected from the motor waves, the electric motor waves in the beginning, and there is a swollen anastomosis here. So the pressure might get higher in the postoperative period, while in here it's obviously diminished. And this has impacted also in fistulas and reflux, because it's good to alleviate the high pressure of the sleeve. Here we have an enhanced endoscopic access. This is not little. This is important. You have one anastomosis less, one mesenteric defect less, and the procedure is a lot faster than a DS, while this is longer than a duodenal switch. There are not too many direct comparisons between transposition and bipartitions, but there are some. A group from Turkey have compared sleeves with mini gastrics, with bipartitions and transpositions, and they came with a better elevation of blood glucose after bipartitions, a better beta cell response with bipartitions, and they obtained with bipartition the biggest decrease in glycated hemoglobin. And they conclude that duodenal exclusion is not fundamental. Another group have compared bipartition with interposition, and they obtained quite the same results in remission, but they consider TB to be superior because it's simpler. They compared also bipartition with Roux and Y gastric bypass, and it's probably better than a Roux and Y gastric bypass for obesity and diabetes also. This group had surprisingly came with the conclusion that it's even safer, which we did not expect, but we use the bipartition in substitution to the gastric bypass because we do not want smaller stomachs, we do not believe in restriction, and we don't want exclusions also. And a Roux and Y gastric bypass cannot be ileal surgery without causing severe malabsorption. So to conclude, I think that the bipartition is easier and faster, but it's not just this, it's indeed better, with less anastomosis, less mesenteric defects, ileum with bile, a drained stomach, a less risk to the gastric suture, probably less reflux because of the drained stomach, an immediate ileal nutritive exposition and exposition of the whole ileum. So I don't see a clear reason for doing a complex surgery like a transposition if you have a bipartition. The bipartition is probably the best metabolic strategy, both for obesity and diabetes, in my point of view. The sleeve is fantastic, but is not enough for many. And the bipartition is probably the best complement for a sleeve gastrectomy. Thank you very much. A big hug to my friends from India. Have very nice friends there, and I love this place very much. Thank you very much.
Thank you so much, Sergio. Excellent presentation, and I believe this session is going to be the most enjoyable session which will remain alive. We have Amar from India who's doing transit bipartition. We have our past president Narvaria, Suren, who is there, always live. Kular, who has large experience in FGB. We have our president Manish Ketan, Dr. Motwani, and others are joining. So I think very intelligent combination. And now we will have another legion to speak on interposition. Actually, it is nothing to replace, but both these procedures intend to use the whole small bowel and intend to minimize nutritional consequences. And that is why we heard about OAGB, we heard about transit bipartition, and now another legion, an inventor and a friend of mine. We will listen to Oreo. Can I request Suren to introduce Oreo, please?
Yes, I'd be happy to introduce Oreo. I'm not able to start my video though.
That's okay. Now we can see you. Yes.
And so it's a pleasure after listening to the exhaustive lecture by Santoro, pleasure to have Oreo De Paula, who is from Goiânia, which is in the sort of heart of Brazil. And he has been a prolific laparoscopic surgeon right from his early days. He has been right at the forefront doing advanced laparoscopy in his 30s, early 30s. He also learned to fly aeroplanes at that very early stage, and he does fly because he does surgery in Goiânia, in Sao Paulo, in Rio, and in Curitiba. I'm not sure where else. He is who I call a thinker surgeon, and I am lucky that I had the opportunity of being trained with Oreo De Paula in 2007 and was able to start ileal interposition after his training from 2008. After all these years when we've been seeing how diabetes has been handled by surgeons and by physicians in India and elsewhere in the world, I find that so many times it is Orio's, his training, his thoughts, and his guidance, which has led physicians to start doing things like C-peptide studies, which they never used to do in the beginning, serum insulin fastings, etc., analysis of how beta cell function is, the clamp ways of estimating insulin sensitivity, etc. So we are really happy to have a pioneer who has studied all these things extensively, has analyzed this, worked with this, and he is tremendous in his technical skills. So when even I've spoken at international meetings, and believe it or not, I have said that I have never had an internal hernia through the mesenteric gaps, which we learned to close, how Oreo has shown us. And people don't really believe it. To this day, I'm saying the same thing of nearly 600 surgeries with no internal hernia through mesenteric gaps, which are closed. So he shows you how to be extremely safe, because as he said, he cannot afford a complication of 0.00001% also. And I think this is fantastic for his patients, and it's fantastic for all of us, especially younger surgeons, also to learn a procedure, even if they think it's complex. But if they learn and master this procedure, they can do any bariatric surgery safely and effectively. So thanks for being with us, Oreo, and we'd love to hear what you have to say about ileal interposition and the fact that that you are going to show that it cannot be replaced by transit bipartition, even if that is an easier procedure.
Thank you, sir. Thank you, everybody. It is really my pleasure to participate in this meeting. I have, very close and good connection to India, a very good number of friends, and also want to thank Shashank for this opportunity. Can I have the video? Good morning or good afternoon for everybody. First, I'd like to end with the topic, metabolic surgery, will transit bipartition replace ileal interposition? My task is to say no. I have nothing to disclose in relation to this talk. The best definition of obesity, metabolic syndrome, and type 2 diabetes depends on how you define or recognize these problems. Different viewing angles change many things. And consequently, how can we use bariatric surgery implications? And I have difficulty in adjectivating the old, current, and perhaps future dystopian reality that what has been done is bariatric surgery in morbidly obese diabetics and not metabolic surgery in diabetics, regardless the weight. Yes, we still have metabolic surgery indexed to the BMI. On the other hand, in the last 18 years, I have adopted the precept of surgery for the treatment of type 2 diabetes to all degrees of weight, and not only for the 20% morbidly obese diabetics. I have also adopted the precept that the target and the success of metabolic operation relies on the long-term control, more than 5 years, of glycemia in order to have an impact on vascular complications and cardiovascular mortality, as currently demonstrated by a number of studies. And finally, I have adopted, on the last 18 years, the principle of targeting different problems, including elevated blood pressure, dyslipidemia, albuminuria, usually associated with type 2 or type 2 diabetes. However, I humbly recognize that I and few others have been vox clementis in Deserto. The operation is still the same since its description back in 2003 and involves a tailored to BMI sleeve gastrectomy. Note that we adjust the sleeve gastrectomy is not a sleeve gastrectomy as we've been using for morbidly morbid obesity, but it has to be adjusted to BMI. And as you can see, we have different steps or different sizes of sleeve gastrectomy according to the BMI. And we also have an adjusted to the total length of small bowel duodenal ileal interposition. Consequent to the choice of treating diabetes, regardless of preoperative weight, the typical patient that we've been doing surgery on the last 18 years has exuberant macro and microvascular disease. The typical patient has a BMI ranging 19 to 34, more than 10 years of diabetes. Hypertension is diagnosed in 70%. Dyslipidemia is also present in 70% of patients. Active coronary artery disease in a third, and also retinopathy and albuminuria in a third of the patients. Insulin therapy is present in more than 50% of patients. So in summary, what we've been doing is surgery for a very diseased patient. Safety is key, and we have shown this in this study back or more than 10 years ago, that we analyzed 454 consecutive patients with BMI 19 to 34. And it was demonstrated after this publication that there was a 0.4 mortality rate and 6.4 major morbidity rate. It is important to emphasize that half of the mortality was related to clinical problems. Again, a very diseased patient. And more than a third of the complications were also clinically related. But it's also, I would also like to point that nearly 75% of the postoperative complications were related to the sleeve gastrectomy. So what we have now? Well, future is no longer future. And all these patients from these more than hundreds of patients have now more than 10 years of follow-up. So future is no longer future. As we were not able to have a clinical control, what we did is to analyze these hundred of patients with more than 10 years of follow-up, dividing these patients in those with and those without cardiovascular disease, preoperative cardiovascular disease. 10 years data, long-term mortality, 2.16%. As you can see, only 0.36% of mortality rate was related to the surgery. In terms of morbidity, we have to emphasize that GERD is really a problem for approximately 16% of the patient, and morbidity that could be related to the operation was present in 2.52% of the patients. But we also have, as you might recognize, that these diseased patients have a price to pay. So we had in the long-term morbidity, as you can see, carotid artery obstruction in 0.72%, heart failure in nearly 2% of the patient, stroke in 2%, nearly 2% of the patients, any other complications. We also have a very interesting finding that is, despite the patients with normal weight, overweight, or those with obesity, grade 1, BMI between 30 and 35, the operation was equally effective, meaning that 60% of the patients have complete remission of diabetes after 10 years. And as we mentioned before, we also look for other problems. And what we were able to get in this for these patients after 10 years is that we had microalbuminuria control in 7. 84% of the patients had BMI below or equal to 25. 86% of the patients have control of hypertension, 82% of hypertriglyceridemia, 86% of the patients had LD, low density cholesterol below 100. In this long-term study from the University of Milan, diabetic patients had ileal interposition compared to clinical treatment. At 5 years, nearly 70% of the patients had A1C below 6 and normal fasting glycemia. In this meta-analysis, it was demonstrated that ileal interposition stands as the most effective operation for diabetics who do not meet current NIH criteria for bariatric and metabolic surgery. But we also made the question if we could do better. And so we evaluated the failures. And it became evident that postprandial glycemia was controlled in the majority of the patients, more than 95% of the patients, according to this study at nearly 5 years. And fasting glucose control was really a problem in nearly 50% of the patients. And we all recognize that endogenous glucose production is the principal determinant of fasting plasma glucose concentration. So I will not have time to get into the details, but the typical phenotype of the patient that failure is often impaired fasting glucose, according to this graphic. And according to one of our previous study, hepatic resistance is key for this group of patients. And so hepatic glucose production and uptake. And so we came with the question, or the Sphinx riddle is, how can we, as a surgeon, approach this pathophysiologic problem? So we decided to add a selective intra-abdominal denervation for reasons that I will not be able to get into the details. The primary goal is to perform a selective abdominal sympathectomy. However, as it is nearly impossible to assure that some parasympathetic fibers are not damaged, we decided to name it as selective intra-abdominal denervation. As you can see with some of these two arrows on the right side of the graphic of this picture, some parasympathetic fibers along the portal vein and also along the gastroduodenal artery. Preliminary 2 years data have demonstrated a real progress with this selective intra-abdominal denervation, as a nearly 90% of patients with A1C below 6 and an impressive 93% control of hypertriglyceridemia. So the answer, or the objective answer to the question is no, transit bipartition will not replace ileal interposition as a metabolic surgery. But there is also the other side of the question, which means that transit bipartition is very similar to jejunal ileal interposition with a sleeve gastrectomy, an operation that we've been using predominantly for morbid obesity. And it was very clear very clear for us since 2006, at the end of this prospective randomized control trial comparing jejunal and duodenal-ileal interposition for type 2 diabetic patients with BMI 21-34. The importance of diverting the duodenum, a 35% remission rate when you have the jejunal in the digestive tract, and 80%, 81% remission rate for the duodenal-ileal interposition. And we also studied years later why it happens. In this publication from 2011, together with the University of Pisa, headed by Dr. Ferranini, it was very elegantly demonstrated that the better effect with the duodenal-ileal interposition had to do with incretin performance. Nothing with numbers, but performance demonstrated by the better potentiation factor when you have a duodenal-ileal interposition. So the data is already available since 2006, and so transit bipartition will not replace ileal interposition as a metabolic operation. And also, according to the published literature, transit bipartition was rarely performed for patients with low, and to emphasize that BPD has the best diabetes resolution for morbidly obese patients, and only 8% A1C control for non-morbid obese diabetic patients, according to this publication of 2019. And finally, we also have to consider that ileal interposition is a legal operation according to the highest judicial court from Brazil, while transit bipartition is still experimental. In summary, it takes extraordinary intellectual juggling and speaking contortion to replace ileal interposition as a metabolic operation. I'd also like to thank a lot of other people, especially from India, Dr. Suhendra Ugali, Dr. Luciana El-Kadri, Professor Ribamar, and many others for being part of this work. Thank you very much.
Very good. Very good presentation. So now hand over to our chairpersons, Dr. Amar, Narvaria.
Yes, I'm coming from Amar and Mahendra.
Yeah. Oreo, have we studied bile at role of bile in controlling diabetes? Do we have any study wherein the bile is diverted, which has significantly improved the hyperglycemia or diabetes?
Excuse me, can you repeat it?
I said the role of bile. Can we divert the bile? See, most of these surgeries, I think the major role is the diversion of the bile. So if we divert the bile to the terminal ileum, will it has effect on metabolic component of diabetes and hypercholesterolemia?
Well, thank you for your... Well,
go ahead, Aureo, go ahead.
Okay. Is this question for me or Mahendra?
Both of.
Okay. Okay. Thank you, Doctor. Thank you, Dr. Mahendra. I think that all of us knows that bio has something to do with diabetes control. We also know that bio has a part or is part of the solution. So what I want to emphasize is that there is not a specific or any specific element that is involved with glucose control. There are many of them. The number two issue, or the second issue, is that the complexity of this disease is immense, which makes evaluation of the different parts of surgeries or elements like bio, like GLP-1, like sympathetic nerves, and etc. weight too difficult for you to evaluate. What I can tell you is that hypothesis is hypothesis. Facts and data are facts and data. So, for example, as Dr. Santoro mentioned, there are a number of hypotheses, but the data is already here since 2006, which means that if we have the jejunum in the tract, and honestly, I like to have the jejunum in tract, the issue is that for metabolic or as a metabolic operation for patients with BMI 1934, this operation with the jejunum in the tract is less effective. That is what we have. That is the data that we have since 2006. Thank you.
Well, going straight to your question, bio is indeed important. Bio and the absorption of nutrients are important in the secretion of GLP-1 and in the secretion of FGF19. I think these have to be shown because we have to study interposition in this experimentally, I think, in this matter, probably with isolated ileum and isolated segment of ileum, because in the interposed segment, there is no bio and digested nutrients are not present there. And it has been extensively studied that it's the absorption of nutrients, not the presence of nutrients, that are involved with this hormonal secretion. So as well as bio, it's the absorption of bio in the ileum that connects to the FXR nuclear receptor that provides the secretion of FGF19. So yes, answering directly to your question, I think that absorption and bio in the segment is very important. I think that before I end this answer, I would like to point to something that I think it's very important. Aureo is a magnificent surgeon and a great friend. We have been in good friendship for many years, and we had done a wonderful progress because many years ago we both together fighting with other classic bariatric surgeries, and now we are not doing this anymore. We are not discussing here sleeves or gastric bypasses. We are not facing older procedures. We are now talking between two metabolic procedures designed to be metabolic and not incidentally designed, incidentally metabolic, as the classic bariatric surgery are. So in spite of our some small differences in our thoughts, I think that in most of it, we are very much together, and I am very happy to be in this discussion now between two really metabolic procedures.
Okay.
I would just like to interrupt you here. The point about the bile that you mentioned.
Swain.
In the morbidly obese group, you have the BPD, which has the best success rate for metabolic, right? And over
Yes.
there, the bile is taken right to the end. The bile is not in the alimentary limb there. Then in the BPD, when you have the low BMI group, you have, as Aureo presented, only a 8% remission rate. So when there is no bile over there also, you've got the highest remission rate with the BPD. So bile is not the only essential factor. Would you?
Surrender. In a duodenal switch, you have the terminal ileum flooded with bile. flooded with bile. So in the same in the Scopinaro procedures. In the interposition, it's absolutely no bile there.
Suren, Sasha, let me just be back a bit in answering Dr. Mahendra. You know, Sergio, as Sergio mentioned, it's very nice. It's a very nice opportunity for all of us to be here, especially because we are raising a special issue that is other type of surgeries being effectively used to treat a terrific disease like diabetes. The second point is that Sergio is a close friend of mine, but we definitely have some differences, which we've been pointing out here. And one of the very first that I would like to express here is that we are, Sergio, in an academic meeting, which means that we have to have hierarchy. And hierarchy is thesis, hypothesis, thinking, opinions is in one level. Data is in another level. You may eventually, or someone may eventually do not believe on the data, but data is data. And the data that we have since 2006 is stronger than hypothesis, thinking, opinions, and whatever else. So we have in an academic discussion stratified or hierarchize, have a hierarchy to clearly define what we are talking about. The number two is point, or the second point is that what I mentioned to Dr. Mahendra is that the complexity of the disease makes so many players, they are so important, and we do not have the element to really categorize what is the whole of each of these elements as the effective tool to treat type 2 diabetes. Sorry for interrupting you, Surendra.
Oh, no, that's fine.
One question to Sergio.
Surendra, let's go to the data. The data says the beautiful work done by Dr. Fiona has shown that it's absorption that brings incretin and all gut hormones, not just FGF19, GLP-1, PYY. They depend on absorption. So in the case that you mentioned, in the duodenal switch, there is a huge absorption in the terminal ileum, in the last meter of the ileum, which is not the case with the transposed ileum, and it is the case in the bipartition, because in the bipartition, our ileum is flooded with nutrients and bile, and the segment is long enough, because we are using now like 230 centimeters of ileum flooded with nutrients being absorbed. So, and going back to the data, there was only two direct comparisons between bipartitions and interpositions, and both of them came to the same answer, that it would be better to do a bipartition.
Sergio, please. Sergio, I would like to stress one point, Sergio, is that please do not mention just these two works. These two papers that you mentioned have so many flaws, so many methodological flaws, that I was astonished when they had that the methodology simply cannot leave you with the conclusions that you raised. So these two works that you mentioned, they have definitely so many methodological flaws that they cannot be used as conclusion as you are mentioning.
Anyway, so
and I can,
for example, in
I can take
the
all
publication, Sergio, you have mentioned in the publication that that GIP is secreted more when the stimulation of the duodenum, and GIP does not help in the control of diabetes. On the other hand, you say that that when the food goes down from the controlled anastomosis, and you want both sides open because then you have less nutritional effects. So you are getting, my point is that in a transit bipartition, you're getting a metabolic effect with the ileal stimulation and getting a negative effect with the duodenal stimulation. So how do you answer that?
Okay, good.
Oh, you're right. You are right in this point. The duodenum has indeed the negative effects, and but if you follow a GI series, a post-operative GI series, you will see that the ileum is filled with nutrients a lot earlier. So in the first spoons during the meal, the food will go straight into the ileum, not to the duodenum. There will be something like 30% of the meal that will reach the proximal parts, but later in a meal, not early. Do you see what I mean?
Would Amar like to say
anything? Let Amar comment. Yes.
Hi. Actually, here ileal diversion surgeries are here to stay. It will be for either transit bipartition, loop bipartition, or ileal interposition, all are going to stay. The only thing is for different indications. For me, initially when I started, I was doing sleeve and ileal interpositions, and then later I shifted to a loop bipartition and SADES procedures. But my indications are for SADES and loop bipartition, I am going to restrict them to 30 and above BMI. And below 30 BMI, I'm doing ileal interposition surgeries. Because like the metabolic effect, ultimately the question is the food has to go through the ileum to induce the ileal hormonal changes. And there is a need for biliopancreatic diversion. So the longer the limb of biliopancreatic, the greater the effect of metabolic effect of surgery. So for people with more BMI, they also need more weight loss. So I use loop bipartition and SADES surgeries for more BMI, like severe and morbid obesity. For lesser BMI people, they can't expect that much malabsorption. So I do ileal interposition surgeries. My questions are two questions for both speakers. One is in transit bipartition or loop bipartition, problem as time goes on, the anastomosis size will come down in some patients and it may disappear altogether. So it may get closed. We have observed in loop bipartition patients. And in problem with ileal interposition surgery is, it's even though it's a very good procedure, it has a small biliopancreatic limb. So it may not have the same effect of SADES or loop bipartition in morbidly obese patients. And it's a time consuming procedure. So even though it's a very good procedure, reproducibility is many people are not able to adopt that because of the duration of surgery. So if the duration, if the surgery is simple, adaptation will be more, reproducibility will be more. So you need to, how to rectify these two problems. For Dr. Santoro, I need to ask you, how are you going to rectify that anastomotic side? And for that, Dr. DiPaolo, duration of surgery.
Dr. Sergio and Oreo, apologies. Actually, we have exceeded the time, but a lot Galvo is waiting on his mobile. But still, I must tell you the whole purpose of having all this discussion is we had MGB on one part, which is getting promoted. We have excellent established results with ileal interposition on diabetes. A newer procedure is being discussed, the transit bipartition, and I believe sometimes we thought of the need for a transit bipartition only when there was an established biliary disease. But it is for all the audience and all the surgeons to know the balanced perspective of each procedure, and no one is going to replace anyone. It was just to make it more interesting for everyone to attend. Every procedure has a role, it will stay, but this comparison and a thought process will give a different perspective to younger surgeons. So I must thank all of you. We'll have the chat box open so that even the questions can be answered and everyone can still listen to those questions. And thank you to inventors. Wonderful thought for us and learning for all of us. Thank you, Seren, and thank you, Meher.
Thank you. I congratulate all you. Thank you, Shashank. Thank you, Gali.
Thank you.
Sergio, Oreo,
Yes.
Hardik,
Amar and Mahindra.
thank you.
Hardik, can we have Dr. Galvo's slide? And can you tell me how much is the duration of his presentation, of his video, so that I can intimate him? Anyway, let me get started. He had just messaged that I'll just give a call whenever we are ready. So Galvo Neto actually is an excellent bariatric surgeon to begin with, and then he became a bariatric endoscopist. And I must very honestly tell you, I learned bariatric surgery from him, and he made my future. He graduated in 1989, and after completing the medical residency program, he took 3 years. He took 3 years to complete. He completed in Sao Paulo. He has multiple innovative endoscopic procedures to his credit, and various advanced techniques of through endoscopy, whether it's a band removal, plication, or even novel metabolic procedures which were endoscopic. And I have seen some first in human trials conducted by him. There is no need to introduce him. He is probably the best known bariatric endoscopist in the world. Hardik, please.
Moderators.
And
My name is Galvo Neto, and it's a pleasure to be among you today. And I wanted to thank you very much the invitation of my dear friend Shashank Shah to speak about it. And the topic of my presentation will be the differences in between the lap gastric plication and the endoscopic plication of the stomach. So as you can see on the screen, the laparoscopic plication starts by taking down the vessels of the greater curvature and invaginating the fundo, the gastric curvature with sutures that can be interrupted, continuous, observable, non-observable, one layer and even two layers. So you can see also the sagittal cut on that, how it's effectively invaginating to that. So what is the laparoscopic greater curvature plication? Is a bariatric surgery designed for morbid obese subjects and has mixed results in literature. The long-term durability have been assessed but questioned, and is the least performed bariatric procedure worldwide nowadays. Also, it is a gastroplasty, and as I told you, not a single part of the stomach is removed besides the vessels and nerves of the greater curvature, and this invagination is very effective on that. Effective at the point that the intraluminal pressure environment of the stomach, that is a low pressure, high compliance system, goes to a high pressure, low compliance system, one similar to what happens in the sleeve gastrectomy. So it works by restriction, by increasing the gastric emptying, and also it can cause minor change in GI hormones that for the paper studies up to now. And in terms of complications, have low rates, and despite the low rates, it had created kind of new ones like the leaks, and the leaks are ischemic, and for the increase of pressure and taking down the vessels causes ulcers and ischemia, and this pressure can lead to leaks. They have mucosal hernias in between the sutures that was described, and it looks like a diverticulum. And the initial days are really challenged, like intragastric balloons due to nausea and vomiting, and prevents an early discharge that can have some of advantage of these procedures, that is the low cost. So among quite some papers in the literature, so we revised around 30 papers of laparoscopic greater curvature plication. We had published, group had published a systematic review and meta-analysis with short and mid-term results. And as you can see here, the structure of a meta-analysis ends up in 8 papers that could be evaluated for that. And this is this graph that can show you exactly what we found in this paper. So The weight loss is significant with the RGCP, but not as the same of sleeve gastrectomy that significantly have better results in terms of weight loss and durability, and has more identified advantage when compared to that. And the gastric plication, the lap gastric plication, has the advantage of being a non-excise technique that you don't excise part of the stomach, and also for the price on that. And you can see here that all the results of this meta-analysis points to advantage of sleeve gastrectomy on that. And nowadays, with cheaper staples, the initial advantage of the lap plication that only being using suture and energy source, they are like low when compared in that position. And how about the sleeve gastroplasty done by endoscopy? So as you can see here, we use very specific device, a double channel scope with device attached on the handle on the tip. It emulates like a needle holder, where we have our grasper in the form of corkscrew like that we dig into the mucosa up to the deep muscular layer, and we put it inside the two jaws that you can see outside. We have a surgical grade needle with proline 2O. Then we close, we exchange the needle, and we pass the needle one side to the other, as you can see globally on that. But we can show you better on this animation that we go to the stomach. Our aim is to work on the greater curvature as the laparoscopic plication. So we, as the laparoscopic plication, start on the incisura, and eventually can mark the anterior wall, the posterior wall. It was the very beginning, so very few groups are still doing that. And with this suture machine, we go to the anterior wall, greater curvature, posterior wall, and there's a different standards of suture. This was the initial one. Again, anterior wall, greater curvature, posterior wall. Then we drop the needle, it will act like an anchor, and then we have a cinch device that looks like not pusher, and we fire another clip. So with that, we can modify the anatomy of the stomach. The intention here is just to work on the greater curvature and on the proximal part of the fundus. So what it is a bariatric endoscopy procedure designed for non-morbid obese patients. So the target population 30 to 40, better results 30 to 35, very promising initial results, and so good that it's enough to start the clinical practice. We have mid-term durability studies, and it has started to be done worldwide, becoming popular nowadays. So what you have on your screen right now, it is like a timeline. So we start in 2012, the initial series, adapting the technique. Then 2013, 14 first larger series, 15, 16 international combined series, and you see that in 2017 you have the first big series coming from Saudi Arabia with 1,000 cases, and as we speak, 19 and 20 level 1 data is being provided by means of what we call the MERIT trial, prospective randomized control trial done in US, a big one. And also our team in 2020 published the Brazilian consensus with a large number of patients, 1,828 patients that we will be evaluating right now. So more than 80 papers published right now, and you can see that even a single paper coming from Cornell with 5 years results that points to initial 283 patients, study up to 5 years with 89% follow-up. That's a very good rate. And the weight loss was around 18.7 kgs, and percent of total body weight loss 14.5%. And the percentage of patients that achieve more than 10% of total body weight loss is 70% at the end of 5 years. During this whole time, 2 upper GI bleedings, 1 per gastric collection that were treated conservatively. And just to know that around 30 to 40 patients get up to the 5 years, but it is there. So you can see the graph of weight loss up to 60 weeks. And you can see here that the drop was very consistent, up to 36, and then a little bit up on 48, another drop of 60, possibly with by a bias or statistical error, having less patients on the 5 years. Also, at least 12 meta-analyses were produced, like this one of the newest one by São Paulo University, meta-analysis that could enroll or put together 1,859 patients with total body weight loss at 24 months of 14.86%. And also the excess weight loss at 24 months of 60%. And the pooled severe adverse events were 2.26, so very low severe adverse events. So you can see here in this meta-analysis graph that if you go down below where are the black losangos, they are the results from up to the bottom, 6, 12, 18 months and 24 months. So all of them over 15% of total weight loss. That's pretty good for endoscopic procedure on that. And this is our Brazilian consensus of zygastoplasty with more than 1,800 patients. That it was a collective effort of 47 endoscopies with a mean of 15 years of experience in a mean number of cases per participant of 87 procedures. They all trained in a very standardized fashion that's very unique for endoscopic or surgical methods, and they had used the U-shape suture, as you can see here, the initial U-shape pattern and a modification of this one that's called square that is being adopted lately. So in terms of complications, less than 1%, most of them bleeding with conservative treatment, too prolonged pain due to CO2, one persistent vomit, one respiratory insufficiency, and very important, 3 laparoscopic intervention, 2 for abscess, 1 for gallbladder puncture and suture. And this is the very first time that a death is reported, and was in a high-risk patient that developed pulmonary embolism, and there was the surgery that indicated that for the treatment. And interestingly also, the results were 18.2% of total body loss, very good results indeed. Also, as we mentioned earlier, we just finished the enrollment, and we followed these patients for 2 years. That's in MERIT trial, prospective randomized controlled trial against diet. You can see by the institution that are participating. It's a very important trial. So I have Mayo Clinic, Cornell, UT, Harvard, Hopkins, and quite some very good private centers in the US. So it's 200 patients. They were randomized to have 80 on the endoscopic procedure, 120 on the diet, and after 1 year they were being crossed. The ones with diet will have the procedure, and the ones with the procedure will be followed to assess the need of resuturing or reintervention for that. So it is a gastroplasty. Vessels and nerves are preserved. We leave the fundus as part of the procedure in order and it doesn't lead to reflux. So this is not a refluxogenic procedure like the gastric plication, not like the sleeve gastrectomy. And the stomach intraluminal pressure is kept at the low levels because of the compliance that keep it, and the peristalsis is kept on that. So it works by restriction, by delay the gastric emptying, and we don't know yet if it changed or not the GI hormones on that. So you can see here, this is coming from Mayo Clinic, courtesy of Professor Abraham Abudaye. So it's a dynamic MRI on the top part to see the heart beating, and on the lower part to see the liver and the stomach that was sutured, but keep the capability of contract and relax over that. So how it works, this is scintigraphy, and you can see the color part with 240 minutes, 3 months after the ESG still retain a lot of food there. And this also this tomography done in the contrast is retained on the fundus even after 1 hour after the ingestion of the contrast. So this is a new data coming from the MERIT trial that you can see here that on the left side are the controls, and then it's the ESG patients in terms of gastric emptying at baseline 3 months and 12 months, how we keep delaying the gastric emptying. complications, as we said, low rates, most of them solved by endoluminal transcutaneous conservative approach. Long-term specific complications are not identified up to now. And it was we were anticipating this slide, the mortality was not yet reported, but our paper had reported the first mortality with the procedure, and is one report among more than 15,000 cases done worldwide in that. So as we told you, that's a collectively, and all the papers like this is a paper that we analyzed 248 patients in between Madrid, Cornell, and Mayo Clinic, and you can see here two pergastric fluid collection, percutaneous drainage, one pulmonary embolism, solved clinically, self-limit bleeding of splenic laceration, and one pneumoperitoneal pneumothorax during the procedure that also treated conservatively on that. So those are the difference in between those procedures. That was the question that Dr. Shashank Shah asked me to try to solve it, and I will end up showing to you that is already being published comparison in between laparoscopic weighted curvature application, sleeve gastrectomy, and endoscopic sleeve gastroplasty up to 2 years. And you can see here was just recently published by the Spanish group in endoscopy, and you see here 296 patients from 4 centers in Spain between 2014 and 2016. So there's a clear advantage in terms of weight loss for the surgical procedures. But the endoscopic procedure on the top, as you can see, 18.5% of total weight loss up to 2 years is not bad at all. The trade-off is that when we see the complications, the endoscopic procedure significantly have less complications than the surgical procedures, and also the patients go home earlier with endoscopic procedure when compared with the surgical ones. So I wanted to thank you very much for your attention, and any questions we can solve it later.
Excellent talk, Dr. De Carlo Neto. As always, enjoyed your talk. Just a quick question in terms of, I mean, most of our audience today are from India. So just considering the Indian scenario, we talked about the laparoscopic plication and also the ESG. So we are seeing wonderful results of the ESG. There's a lot of renewed and amazing interest in the entire community, both doctors as well as patients in India. Just a quick question regarding comparison of these two procedures. So let's say back in the day when we were still doing the sleeve plications, lap plications, we were suturing from top to bottom, and yet we couldn't find much result. There was a high failure rate. Now we have the ESG where we are leaving the fundus and then we are plicating the body and the, up to from up to incisura up to the body and then up to the fundus, but leaving the part of the fundus alone. In your opinion, you think similar architecture, if you replicate laparoscopic laparoscopic plication, do you think we can replicate similar results what we have seen with ESG in the long? I'm only looking at it in the cost perspective, because ESG today still costs a good amount of money in Indian situation, whereas a plication costs hardly anything. So just wanted to know your opinion on that.
So thank you very much. Thank you very much for your question. And it's an honor to be here. And more than an honor, it's a joy to be here among you. Thank you very much, Shashank. Thank you all. Thank you for the question. There's a very interesting question, and you nailed that. You really nailed that. So what if we replicate the anatomy, what we're doing endoscopically, with laparoscopically? So I can tell you the complications that comes to the laparoscopic applications is that you have to take down the vessels and the nerves of the greater curvature.
Right.
So and you do that in such a good way, in such an effective way, that this inner environment, pressure-wise, you replicate the sleeve gastrectomy. So it means that the tube that you're doing, it will be inelastic, and you create a hyperpressure system, and it's be very low compliant. Even if you left the fundus, it will be even worse, because it mimics the pressoric system of the sleeve gastrectomy. what we do is that by preserving the nerves, the vessels, and just invaginating from inside, so all the compliance of the stomach and this phenomenon of the stomach, physiological phenomenon the stomach has, that is the gastric adaptation. It means that, so we all know that stomach can handle up to 5 liters. Not now with you, not now with me. But if you have a very fatty meal, 15 minutes, 30 minutes after, it will handle. So this capacity of gastric adaptation, it is preserved on endoscopic procedure, while if you do the laparoscopic procedure, it is not. So leaving the fundus in a lap application will lead to the same problems when you leave the fundus with the sleeve gastrectomy. The poor quality of life, the reflux, and even weight regain. And understand also that if you have a narrow, and it's not me, it is the Laplace law of physics. So if you have it narrow and inelastic, everything that is on top will dilate. So why our fundus don't dilate? Because it is not like they are trying to win an obstruction. And we are also demonstrating with the studies in Mayo Clinic and around that it is not a restrictive procedure. It is just it impacts on the weight, on the gastric emptying, as that said. But I think that if you can invaginate the fundo or the greater curvature without taking the vessels by laparoscopy, and you guys are very creative, I think you can do that, then it's the same. It is the same. And basically we're talking is a pressure wise, it's like elastic and inelastic tubes to do that. And on our side, you can we can be blamed to not work, but we're not gonna do harm, and that's very important for that. And the other thing is that, like when you say the word endoscopy, that's very interesting. So the patients that come to us, you're never gonna see them, never in your life, because it's the patient, when you say the word surgery, they run away. If I say the word surgery for my patients, they run away. They are even aware of the cost, and they will pay whatever cost needed because they want something that is non-surgical. And I'm not saying that surgical is bad. Believe me, working with for me, 20 years, I love surgery, and that's a good part of that. I'm not biased with my perspective or not. In terms of cost, so we are experienced. So we have lived this whole life of 20 years, you, me, Shashank, everybody. And we remember how much it costs for India, one staple. Do you remember 20 years ago? So imagine that we became scale. Our Chinese fellows, ourselves, we're gonna end up with machines, endoscopic suturing machines, and we're gonna lower the price. And you have to be lower the price. So, but we are in the initial, I think maybe in the initial way to do that. And interestingly, also, why the application lose, laparoscopic application lose the battle? They position themselves as a bariatric procedure. So everybody who gets one expects a bariatric power to weight loss safety in that. We don't. We want the lower BMI patients. We want to add patients, to add the scale and to be another tool to help. Sorry for the long explanation.
Very good answer. Very good answer. Thank you, Gero, for being a part of MetaSearch right since 2005. And I must tell you, he is a global endoscopist, available 24/7 from anywhere, any country, any place, whether in flight or anywhere. Wonderful answer. And I wanted everyone to understand this difference between the change in stomach compliance, innervation, blood supply. Maybe that's one of the main reasons why endoscopic sleeve gastroplasty is so successful. Very good question, Dr. Nand Kishore. Thank you, Yalva. Sorry to bother you from a meeting. This was very
my pleasure.
Useful. Thank you
My
so
pleasure.
much.
Great to see you.
Stay
Nand.
safe. Namaste. Stay safe.
Stay safe. Nandakishore, you can stay here, and Hardik, we can go to the next session, and that's still more interesting. We have Dr. Randeep Pradhavan, Dr. Raman Goyal live here, and Sergio is going to speak. We are going to skip Almino's presentation, but the main point here is if you see all our discussion and procedures, now we are looking at total small bowel length, total small bowel length available for absorption, the alimentary length, the biliopancreatic length, and there is really a question mark how intestinal adaptation compensates and regains weight or diabetes. Looking at this fact, what would be the impact of total small bowel length in long-term results, maybe after a sleeve gastrectomy or a gastric bypass or procedures where we are blind to what the common length is, and with the procedures where we do measure the total small bowel length, I had a thought in my mind, maybe those who have longer length or better compensatory mechanism in their small bowel probably regain weight more, just like our major restriction and short bowel syndrome patient. Surprisingly, some patients can sustain very well and some don't. So, what would be the impact of total small bowel length on long term weight loss and maintenance after various procedures? And we again have Dr. Sergio Santoro, who has agreed to speak on this subject. He's already introduced, and we heard him about his invented procedure. Sergio, please.
Again, it's an honor and a pleasure to be with you. I'm going to talk about the length of small bowel limbs and weight loss. Is a short common channel really necessary? We have been working with the bipartition for many years, and it was developed to be pure metabolic surgery, a sleeve empowered by the early stimulation of the ileum with no malabsorption. But in the beginning, the common channel probably was still too short, and some signals of malabsorption still remained. As the results were really potent, we thought we had room to enhance this common channel to completely avoid malabsorption, and we did it. We did it 3 times during this period, and we compared the results. We were expecting to lose some efficiency, at least a little bit of the weight loss, but it didn't happen. And we could not understand easily why, because we were with diminishing malabsorption. Indeed, the longer common channel was a little bit better in terms of weight loss. And we imagine that the answer for this is that this segment has no bile and no digestive nutrients. This could jeopardize its endocrine function. And so this segment might not work well. While this segment here with bile and digestive nutrients could be a better endocrine organ. So this would be a defective ileum, and this would be a fully functional ileum. Holo is a word, a prefix in Greek that means complete, whole, with all its elements. So this is the holoileum hypothesis. The ileum needs all its usual contents, biliopancreatic juices, digestive nutrients to work well. And the lack of these elements might jeopardize the endocrine function. So we could win twice with less malabsorption and better gut signals. Well, bile acids, as they enter the gut, they are transformed in secondary bile acids, and there are receptors both in the membrane and also intranuclear for these bile acids. The TGR5 is the most important of these bile acid receptors of membrane, and the FXR probably the most important of the intranuclear, although there are others that are also important. TGR5 activation, it stimulates energy expenditure, it suppresses glycogenolysis, it is related to gallbladder filling, it reduces inflammation, but most important of all, it's related to the secretion of GLP-1 by the enteroendocrine membrane. So this knowledge makes us rethink about the procedures we know. As I just mentioned in a previous talk, there are procedures that have a segment of ileum that has no bile inside. So this might jeopardize the good function of the surgeries, because GLP-1 is indeed very important, but also other hormones. What do these endocrine cells sense? They sense the presence of nutrients or its absorption. Well, it seems that it's absorption. Long-chain fat acids, they are absorbed and they are felt by the basolateral receptors to obtain GLP-1 secretion. The same happens to glucose, but also it happens also to protein. So it's nutrient absorption more than just the presence that is fundamental for to obtain the endocrine signals produced by the gut. And this nutrient absorption is not just related to GLP-1, but also PYY, oxyntomodulin, and FGF19. In the case of FGF19, it seems to be the most important of all, the effect of bile, because bile activates the farnesoid X receptor, the FXR, and the FXR it triggers the production of FGF19, and this is related to the inhibition of gluconeogenesis, a very important step in metabolic surgery. But the activation of the FXR increases insulin sensitivity, not only in the liver, but also in peripheral tissues. And it reduces the levels of triglycerides and free fat acids. So it's really important in metabolic surgery, because insulin sensitivity is in the core of our problems in metabolic syndrome. FXR also is important in intestinal defense, as it controls bacterial growth and it maintains mucosal integrity. We really think that the excluded segments have a not normal mucosa. FXR it protects against liver and intestinal carcinogenesis. It has been shown that FGF19 is really important in metabolic syndrome, but it's the most important thing to say in this talk is that it's not produced by the enteroendocrine cells. It's produced by common ileal mucosa. When you see the differentiation of the stem cells in the mucosa, it will generate enteroendocrine cells, but enterocytes are, and it is the enterocytes that produce the FGF19. So we think that the refined modern diet, being fastly absorbed on top, has caused a duodenojejunal hyperactivity, endocrine hyperactivity, followed by a jejunal hypertrophy, which makes it worse, the ileal hypoactivity. When you do a bipartition, what you observe is a ileal hypertrophy, and this is hypertrophy of mucosa, cells that produce FGF19. And FGF19 is really enhanced after surgeries like the bipartition. So we think that duodenojejunal hypertrophy is really a part of the problem, as it makes nutrients disappear from the ileum. While ileal hypertrophy is indeed an objective in metabolic surgery, as this mucosa is the producer of one of the most important signals of the distal gut. And we know it because procedures that bring nutrients to the jejunum are different from those that send it to the ileum. The BPDs, they enhance insulin sensitivity and they provoke lower insulinic response, which is really important to these patients. And we know that only ileal procedures like the jejunal ileal bypass, where there was no exclusion, you can see it here, but all the others ileal surgeries that are available, only ileal surgeries are capable of inducing remission greater than 80% in diabetes. We can check this in the work of others. The work of the group of Mariana Monteiro has compared the duodenal switch to SADI, where the anastomosis is made in the same place, but the common channel is completely different. Basically, it's a comparison between long common channel and short common channel. And the long common channel produces more GLP-1 as well as more insulin. Others have made the same comparison, duodenal switch against SADI. And what they observed is that there are more complications here, nutritional and diarrhea, while the final BMI is pretty much the same. So now we can understand that a longer common channel can reduce malabsorption, but enhance distal gut endocrinal signals. So the weight loss might be quite similar. This brings us to this thought, to this evolution, where I don't see any reason for a classic duodenal switch to be made anymore. It's very much clear that a SADI procedure is simpler, one anastomosis less, but also less malabsorption with the results that are pretty much the same. And if you realize that the exclusion that were made for malabsorption, it's not necessary either. So we come for the bipartition, which has results that are pretty much the same of a duodenal switch, although a lot simpler, even simpler than a SADI, and with total access to the duodenum and even less malabsorption. So we think that this metabolic thoughts may lead us to better procedures. So nutrients must be absorbed, not just present in the ileum, to obtain the potency in metabolic surgeries. Short common channels bring us more complications, while long common channels, less malabsorption, and probably a better metabolic effect. Thank you very much.
Some new excellent points driven. We have our moderators, Dr. Randeep Fadavan and Dr. Raman Goyal. So I'll keep this open to them. So these are actually topics which are not commonly discussed in our meetings, OC or whatever. Randeep, it's open for you to comment, ask any question and discuss, while I'll connect to Sergio Antonio Torres. Mahendra. And I think Manish Ketan was also there if he's here, our president.
Excellent talk, Sergio, and enjoyed your talk. And so first question is, when you say that you require a longer common channel to get the best benefits of weight loss, what would be a longer common channel, if you can describe that, or in numbers, what would be the exact longer common channel when you say that?
Sergio, can you hear us? He has messaged that he has an interruption in the internet connection. Let me just call him and let us try.
I think it is more than 200 centimeters. That is what I think everybody means, having a longer common channel. See the previous process which was studied.
Mahendra, you can be a little louder.
I said the previous process which was studied were 50 centimeter common channel in BPD, 100 centimeter duodenal switch. So I think anything which is more than 200 centimeter is considered a long common channel.
So that means what he's basically suggesting is that the minimum that you require is 200 and more, and nothing less than 200 centimeters would be an ideal there.
Yeah, that is what his poster has shown.
Looks like some of the Indian studies showed that even that is pretty low for Indian population. So based on the dietary consumption, so I think one of the hypotheses is what the Indian population requires is around 3 meters of common channel.
Even 3 meters or 350 centimeters also, some people will be having problems. So I started bypassing fixed percentage rather than fixed length of common channel. So I'll be restricting bypass to less than 55% in SADS and loop bipartition. So when I was keeping 250 centimeters, malabsorption was 40%. When I reduced to 350 centimeters, it was around 10%. When I changed that to percentage bypass, it's almost nil. So for Indians, its situation is slightly different.
And the weight loss at the end of whatever 2 years, 3 years was similar, is it?
Is similar. It's not much different. Even with 350 centimeters or 400 centimeters, the biliopancreatic limb is almost 4 meters. So biliopancreatic limb length is still more to induce a good amount of weight loss.
So Amar, sometimes recently I saw one patient with almost 12.5 meters of intestine, small intestine. So in your formula, so what would be the length of your common channel based on your today's practice?
So I'll be restricted to 55%, not more than that. So I
you
have a bad experience with 350 centimeters also. I had to reverse one patient with 350 centimeters, one 250 centimeters patient I reversed. So when I reduced to 55%, regardless of the total length,
right.
So I'm calculating based on the percentage, not more than 55%. So I compared that more than 55% problems are more.
I see. So in this given patient of 12.5 meters of small intestine, then you would have a common channel of probably around 5.5 meters?
Yes, around that, like 12 into 55%, like.
Right.
Is almost thinking in the lines of what Sir just suggested. But I believe that even though we read all Western literature on common limb lengths, there is no study to evaluate the total mucosal or real internal length of the bowel and the functional length of the bowel. And maybe with type of diet and genetics we have, we need more common channel than maybe a white Caucasian or someone else.
So one question, Shashank, here that I mean, if we are not comparing transit bipartition to an OAGB, but just mentioning that there is data to again suggest that if you have a BP limb of 150 centimeters in an OAGB, the results are almost similar to what you can get at 200 centimeters and above of a biliopancreatic limb in weight loss. You may have nutritional problems, of course, if you go up in BP limb, but the weight loss is similar in long term. What are your comments there? That just 150 centimeters, that's where all the absorption and so you don't actually need to bypass or don't need to have a biliopancreatic limb more than 150 centimeters, irrespective of the total bowel length.
Absolutely. This is an intelligent question, and that is probably what I wanted to have discussed. And if Sergio or your live, they can still join and discuss. So the question was, if given a choice that you have a very convenient method of measuring total small bowel length in an individual, would all bariatric surgeons like to know it, maybe while doing the sleeve or Roux-en-Y or any other procedure, or even while treating a patient? That is the main question, because here slowly, like how we said, the limb lengths don't matter, the anastomosis diameter doesn't matter. We're again coming to a point where even the common limb length doesn't matter and the mechanisms are different. And this was the main purpose to be driven into the minds of everyone, and maybe discuss more on it. So I keep it open for all senior colleagues and friends. You can give a comment on this.
Mahendra, your comments on this, please.
Here measured total bowel length and never decided posture on depending on the bowel length. So I cannot comment on. Only I have done few BPDs for the hypercholesterolemia where I kept a common cell of 100 centimeter, and I have done cholecystoileal anastomosis for severe hypercholesterolemia. 2 of these patients, but I'm still studying them. Only 2 patients, more than 2 years now, and they are doing good in terms of hypercholesterolemia. These are only thin, lean patient with metabolic problem of hypercholesterolemia. So I don't have much experience on the length.
So regarding, can I answer this question?
Yes, Amar, because you do a lot of transit bipartition. So your comments, yes.
So actually, we started measuring total bowel length for all patients since 2016. So initially, I was measuring from one end to another end. Later, over a period of time, I realized that measurement should be a little bit different. We need to start from both ends. So I started measuring from ileocecal junction. I'll go up to a proposed location like 350 centimeters. I stop there, I'll mark there. Then I'll go to DJ flexure. From there, I'll come to this already marked position. So if you start measuring from 2 ends to one common point, it's easy to measure rather than from one end to another end. That's one thing. And second thing, initially we were using marked bowel graspers. Later we changed because like for Karl Storch bowel graspers, the Karl Storch mark which is printed up to the K level, it's 5 centimeters. So instead of preparing marked bowel graspers, we start using these bowel graspers. So it should be like measurement should be like a slightly stretched bowel on the midway between the mesenteric and anti-mesenteric end. So not on the anti-mesenteric or mesenteric, it should be midway in between, and it should be stretched like to measure that one. So if you don't do that one, measurement will vary. If you measure 2 or 3 times in the same patient, measurement will vary. So we start measuring, and then over a period of time, we realize that percentage is more important rather than fixed length. So, and we wanted to preserve pile rest and first part of the duodenum so that we can bypass more length of intestine, and the effect of we can allow the nutrients to go into the ileum. So if you, for example, if you take OHEP and MGB, we are bypassing less. If you try to bypass more than 2 meters, you are going to land up more problems. But in SADIUS and loop pipe partition, even if I bypass up to 4.5 meters or 5 meters, I am getting less problems as long as the biliopancreatic limb length is, common channel length is more than 300 or 350 centimeters, and the biliopancreatic limb is less than 55%. So when this is so, problems are less. The only reason for this one is, and this possible explanation is the preservation of pile rest and first part of the duodenum.
Thank you. Thank you. Please stay with us. Mahendra and Amar, I have another question and session for you. Now, Hardik, can we have Dr. Antonio Torres' presentation? It is why is pylorus preservation so important? Duodenal exclusion with or without pylorus preservation. While I am trying to connect him and request him to join, we can have his presentation. Dr. Antonio Torres, past president of IFSO, doesn't need any introduction. He's professor of surgery at Madrid, Spain. He leads general surgery department and hospital Clínico San Carlos. President of IFSO 2011 to 12, chairman IFSO's board of trustees 2015 to 2019. He's been involved in bariatric and metabolic surgery since 1985 and pioneered a new hypoabsorptive procedure, SADI-S, which is gaining more popularity, and that is why this presentation. Hardik, please. You can all have your audios muted and even
Moderators calling. Moderator calling.
Good morning, my dear friends. First of all, I'd like to thank you, Dr. Chanchaksha, for allowing me to share with you this extraordinary event that is Metasur 2021. My topic is going to be to share with you some comments about the pylorus preserving procedure and long-term outcomes, and why is pylorus preservation so important. This is my disclosure, but the most important disclosure is what we do at our institution in Madrid, the Hospital Clínico San Carlos. We perform, regarding the bariatric metabolic procedures, almost 45% of our patients submitted to a sleeve as a main procedure or a two-step procedure, and then perform a SADIS procedure. We still do 24% of Roux-en-Y gastric bypass, 24%, the same percentage of SADIS procedure, and we are performing many revision procedure at the time goes by around 12%. Well, we have at present time many surgical endoscopic approaches for dealing with patients with overweight and some metabolic associated disorder. But within that, some years ago in 2012, Mr. Rochlin from New York, he hypothesized that the preservation of the pyloric valve would prevent dumping and is maybe a better physiological alternative for bariatric surgical procedure. And so at this time, we had, and now at present time, we have many surgical options that all of them preserve the pylorus. Here you can see the transverse partition, or SASI, or SAHI, the ilia interposition, and then we have the banding sleeve ring, and then we have some others procedure where I want to focus on them, like it's going to be preserving the pylorus and diverting excluding the duodenum, like the SADIs, the proximal SADIs of the duodenal bypass of the standard duodenal switch, standard Roux-en-Y duodenal switch. The pylorus preservation is going to be important because the pylorus is the body's natural flow valve. The skipping the pylorus prevents dumping and may also prevent some other nutritional abnormality because, as you can see in the next slide, preserving the pylorus, we can improve the absorption of many products, such as proteins, vitamin B12, folic acid, and some ions like calcium and iron. Of course, by preserving the pylorus and the part of the stomach, we are preserving also the secretion on some important substances like chloric acid, pepsin, gastrin, and intrinsic factor. So preserving the pylorus is going to be important. The other component of these the surgical techniques are the influence of the duodenal exclusion. Of course, there are many actions, but overall, the changes in the metabolism of the bile acids regarding the TGR5 receptor and all, the different composition of the remaining coming earlier to the distal bowel is going to be very important regarding the influence of the duodenal exclusion in getting weight loss and in getting the improvement of many metabolic effects. We are going through this agenda. We are going to talk comment some operative training issues and some weight loss approaches, and the improvement of some comorbidities, and finally to deal with complication of this procedure. Regarding the operative technical issues, here you can see the differences between the BPD, the Roux-en-Y DS, and the SADIC procedure. Regarding gastrectomy, the quantity of stomach we remove, the duodenal division going to be at the same level in the three procedure, the gastric drainage, performing anastomosis, generally a root duodenal in the duodenal switch and the loop duodenal in the SADIC procedure. We don't do another anastomosis in the SADIC procedure, excuse me, as we do with the duodenal switch and the BPD technique. The common channel is different, it's shorter in the BPD, and it depends of the different approaches going to be variable in the SADIS and the standard Roux-en-Y duodenal switch. Regarding the duodenoscopy, we don't do in the BPD, and we do, the iliac anastomosis in the other two procedures. Regarding, the different variants of the SADIC procedure, I would say, one is the SIBS, preconized by Dan Cotton and Miss Rowling in US, the differences between this and the standard SADIC procedure that we perform. And the proximal SADIC, I would say, the duodenal bypass is going to be very frequent in the East country, like China, Taiwan, of course, India and Japan. The difference regarding the gastric bougie is going to be narrower in this technique. In our technique, we do a very wider sleeve with a 54 French bougie, and the SIBS or the American approach going to be the bougie between 40 and 42 French. Regarding the length of the bypasses, the interesting going to be 150 through 300 in the proximal SADIS, and going to be depending, because we don't count, case by case this approach. The length of the common channel is going to be between 200 to 250 and 300 at the present time. 300 in the SIBS on the dissection of the SADIS procedure, and going to be I don't say they're going to be malabsorption. The hyperabsorptive procedure we will comment later on. Of course, the clinical outcome going to be similar to the BPDDS and superior to the Roux-en-Y gastric bypass in this end. The proximal SAD is going to be more similar to regarding the clinical outcome to the Roux-en-Y gastric bypass. Let me share with you, this cartoon, gave to us for Dr. Caetano Marchesini, pointing out, that the most important technical issues regarding the SADIC procedure. We're going to be performing a not very narrow sleeve using a 54 Vg. At the beginning, we start performing the anastomos 200 from the ileocecal valve, but now we are performing 250, and in some cases, as you will see, 300 from the ileocecal valve, similarly to some cotton and misworking approach. I'm talking about the SIPS procedure. Here you can see some cartoon regarding, the way that we are performing our sleeve. If 54 Vg inside, we are very close to the Vg, and in this way we perform a not very narrow sleeve. We distracted the duodenum as far away as we can. We don't divide the right gastric artery. We don't perform reinforcement in this the duodenal division. And then we wing up the distal ileum and perform a tension-free duodeno-ileostomy. Here you can appreciate, you can observe, you can realize how comfortable the surgeon is performing this hands-on duodeno-ileostomy. 2 layers that you will see here. This is the pyrosis over there, and we are performing a 2-layer hands-on anastomosis. It's very comfortable and very convenient for the surgeon to perform this kind of the SADIS procedure. Regarding, the weight loss aspect, here you can see our updated experience 10 years. You have to take into account that we started our procedure in 2007, and now here you have a weight loss 78%, total was 34% at the normalization of the BMI. If we observe, the numbers of the standard duodenal switch, the Roux-en-Y duodenal switch, this paper published by Hess and Hess in 1998, but 100 months after the operation, going to be a very stable number regarding the excited weight loss. And if we compare with our experience in the red line, it's very, very similar. It's a comparable weight loss regarding the standard Roux-en-Y duodenal switch 10 years after a procedure. We are pending of publishing our updated 10-year result in our patients. And regarding the failure of the SADIC procedures in getting 50% of weight loss, in our experience, it's only 5% of our patients don't get this aim of losing 50% of their exceed weight loss. Regarding the controlling or the improving of the comorbidities, mainly type 2 diabetes, SADIS procedure, or pylorus preserving and duodenal exclusion procedure, we can get, at the end of the day, this is our 5-year result, updated result regarding is 72% of our patients under remission, no treatment, and hemoglobin A1C less than 6%. If the patient at the beginning had been treated with insulin, 47% were free of their diabetes 5 years after the SADIS procedure. And if the patient at the beginning were with initial oral therapy with anti-diabetic medication, 89% were under remission 5 years after the procedure. But not only the quantity, but also the quality, because we were talking about the importance of maintaining the pylorus and the antropyloric pump, a difference with the Roux-en-Y, another non-pyloric preserving procedure. Here you can see we perform a study measuring in a continuous way for a week the glucose variability in our patient after complete remission. And we compared 12 patients with Roux-en-Y and 12 patients with SADIS. And here you can see how the patient under the SADIS procedure have, a glucose level less than 70. It means hypoglycemic was worse in the Roux-en-Y compared with the SADIS procedure. And the percentage of patients with a normal blood glucose level between 70 and 140 was better in the SADIS procedure compared with the Roux-en-Y. And the percentage of patients with a glucose level higher than 140, it means hyperglycemia was worse in the Roux-en-Y compared with the SADIS procedure. It means that the SADIS procedure maintains, the availability of the procedure in a much more stable way. Regarding the complications, here you can see our revision we published in SOAR 2018. This is the SADIS complication, anastomotic leak 0.6, anastomotic ulcer, the marginal ulcer 0.1, bile reflux very low 1.1, and there is no stricture because there is no ulcer, because the pyrrhus is protecting this anastomosis, this hands-on or stapler anastomosis. And here you can see that the damping, if we don't preserve, not only the pyrrhus, but also the antropyloric pan, is going to be very important to protecting against the dumping of this syndrome that hypoglycemic, hyperinsulinemic status sometimes going to be very difficult to differentiate for the damping syndrome. Here you can see the other important complication. This is the one anastomosis gastric bypass marginal ulcer perforation. Here you can see the extravasation of the barium contrast, and here you can see the perforation of the ulcer. Going to be a very important cons of the one anastomosis gastric bypass. Regarding the bile reflux, it's going to be very important because the pyrrhus prevents a massive bile reflux into the stomach. But it's happened, we have our antropyloric pan regarding can expel this content into the duodenum. So this preservation of this area, don't dividing the right gastric artery, is going to be very important in terms of getting a physiological duodenogastric reflux. We already studied this with this paper we published recently in SWOR in 2020 with the group of Martin Bussen and Marcus Reiser, comparing one anastomosis gastric bypass versus SADIS in patients submitted to failed sleeve procedure. And here you can see, regarding the weight loss, very similar. We compare 42 patients in each arm. Regarding the weight loss, very similar, a little bit better with the SADIS procedure 3 years after the operation. But the most important thing regarding the adverse events, the classification, the Clavin, using the Clavin-Dindo classification. And here you can see that the symptomatic bile reflux was worse, in the one anastomosis gastric bypass. It means non-pyloric preservation procedure, 26% compared with the 5% of the symptomatic bile reflux in the SADIS procedure. So it means that the pylorus preservation and the preservation of the antropyloric area is going to be very important. And why are going to be these differences? Probably the most important going to be some potential neurohormonal differences between the standard duodenal switch and other non-preserving pyloric approaches. The most important thing, we don't divide the right gastric artery we are preserving in the SADIS procedure, going to be here, the right vagus intact is going to be intact. Going to be, even though we cut the left, but we prefer the right in this. We can very nicely, the other differences are going to be regarding, the exclusion that is going to be very important. And, and this proximal reflux of food into the proximal duodenum can be solved by the contraction of this antrum that we are preserving. And here you can see, it's a slide, it's a picture for our procedure. This is the right gastric artery, this is the posterior part of the duodenum, and we are not dividing this, we are preserving the innervation, the vagus innervation is the lesser curvature. It's going to be important in terms of avoiding having, excuse me, a very important biliary reflux, ilioduodenogastric reflux. We can maintain this area, are going to be, in our opinion, very important in getting this success. So there are other, non-pyloric preservation, like the SADIS compared with the one anastomosis gastric bypass and the SAHI and the SASI. So what is the problem regarding non-preserving this area and non-divided duodenum after the period, non-preservation of the period? Of course, there are some, this procedure have duodenal occlusion, but not pyloric preservation. Are going to be a very important technical and physiological point. All those techniques are feasible, But of course, if we don't preserve the pyro, we can induce the Stumpen syndrome, as we already said. We can induce some of those hypoglycemic, hyperinsulinemic status, and we can allow the biliary reflux in the gastric cavity. The controversy of the on increasing of facilitating the appearance of the gastric cancer, but for sure there is no doubt that the marginal ulcer, an osmotic structure, a bile reflux is going to be very important. And the main reason, because I think, many teams or many groups don't do that, is the fear about the duodenal dissection. And in our opinion, it's going to be a problem because the learning curve is going to be very nicely managed. In this way, at the end of the day, the patient submitted to preserving pyloric approaches and duodenal exclusion procedure, you only increase in quality of life because, it's going to be very important. We demonstrated in long-term paper recently published by some teams. So I'd like to thank you all very much for your kind attention. I hope, the MetaShark 2021 going to be a big success. I congratulate Dr. Shansha for this initiative and for allowing me to deal with this issue. So I think, we have to stop recording now.
Thank you so much. Wonderful presentation. Hardik, can I have my video on, please? Thank you so much. It was really a pleasure and honor to have you here for this meeting and wonderfully presented explanation.
Hear it. We can't hear it.
Shashank, I think you're muted. We can't hear you.
We cannot hear Shansha.
So increase your device volume, sir. Increase your device volume.
Device should stop when we are speaking. Device should not go down. We are not able to hear Shashank.
So meanwhile, when Shashank is fixing that, congratulations, Professor Antonio. Enjoyed your talk. Just a few questions here. One, you showed in your case mix that more than 50% are sleeves. There is still 24% Roux-en-Y gastric bypasses and 22% SADI-S. So what are your indications for a SADI-S procedures?
Okay, well, going to be a very important question because now we offer a SADI procedure at the first step. I mean, it's as a one operation, direct operation to those patients with a high BMI, around 50 BMI, and also on those patients with very metabolic profile. I mean, type 2 diabetic patient, dyslipidemic patient, and high cardiovascular risk patient. We have to choose the SADI procedure for this patient. Then we have now another subset of patients that we are submitted to a SADI as a plan two-step procedure. Very heavy patient, a BMI around 70, 75, heart attack, some problems. We plan to do a two-step. We talk to the patient, we are going to do the sleep first and then wait and see. In our recent publication regarding this approach, it's working as well as to perform SADIs as one surgery.
Thank you. Dr. Shashank, we can hear you now, please.
Oh, very good, very good. I think the battery of the caller mic was gone. Anyway, thank you, Dr. Torres. It was wonderful to have you here. It's really an honor, an inventor, and very well covered points, importance of duodenal preservation and implications of duodenal exclusion without preservation, very relevant with our discussion on one anastomosis, gastric bypass, transit bipartition, ileal interposition, where there is probably a mix of duodenal exclusion or pylorus exclusion. Mahendra and Amar and sir, I have one question the next session is probably going to be discussed here, like how we have stoma dilatation in any other anastomosis. I remember in 1 or 2 cases which I did live in Mahendra's conference, I found that even the pyloric stoma was dilated when the part of the duodenum beyond pylorus was very small. So over time it gets stretched. So like any other stoma dilatation, does pyloric stoma get dilated and does it have any implication? I keep it open for everyone's
I
discussion.
think sleeve is a hyper pressure procedure. So both the stomas are getting the same effect, like the G junction as well as pylorus. So G junction get dilated faster, but I think pylorus also gets some dilatation on long term if the G junction is not dilating. So at least one stoma will definitely get affected. So one question I want to ask Dr. Antonio, welcome once again. I enjoyed your talk. And only thing is, you said you do it as a two-stage procedure, but there's hardly an indication in our practice of two-stage procedure. Like the anesthesia given for sleeve gastrectomy versus SADS is same. Like I don't think we have any anesthesia which is of half an hour or less than 1 hour. So we anyway finishes surgery within 1 hour, irrespective of what we do, sleeve or SADS. So why you want to do it a two-stage when you can do as a single stage?
Majority of thank you, Dr. Mahendra. It's a pleasure to see you again. You know, it's my pleasure to have with you guys. You are so kind for inviting me. But your question is very, very important. You know, I would say that the majority of our patients we do now first step procedure, one surgery procedure. But there are some cases, as I mentioned previously, that very high risk patient. Listen to me, imagine a patient with a couple of heart attack, 80 BMI, 80 BMI, very, very risky patient. I think in those patients, just to do a sleeve is a huge operation. Even, you know,
Agreed.
to deal with this is a huge operation. So we always say to our patient, well, we'll try to do our best and to complete the procedure in one row, in one step. But sometimes, you know, the intraoperative findings, anesthesiologists, you know, the general status of the patient during surgery advise you to stop and to do a sleeve. There are very few cases. But the most important piece of news, Mahendra, is our own experience. We compare first and one step and two-step patients. And in the end, you know, 5 years, the results are very similar. So this approach allows us to, you know, to be comfortable with this two-step approach. But I agree with you. I share your approach that it's better to do just one operation, because it's another issue here is the economic aspect, because many companies only pay for one procedure. So in some countries like US, but in Spain, we have a national health system approach. So our government, you know, doesn't matter, you know, to pay for two procedures, right? It's another point, you know, to take into account to make the best for us.
Excellent discussion. Dr. Antonio, I have a question. Have you seen that the pyloric stoma dilates over time and becomes a wider stoma, and maybe the effect of this pylorus preservation is compromised to some extent? Have you seen that in your experience?
I think, you know, I try to share with you what we think is the key of this procedure. Is don't divide the right gastric artery, because in this way, as I showed you, we are preserving the vagal innervation of the lesser curvature. So to preserve not only the blood supply of the right gastric artery, but also to preserve the innervation of the vagus nerve is going to be very important for maintaining the pylorus contraction and dilation. It's not a paralyzed pylorus. This is the reason, of course, if you paralyze the pylorus, if you denervate all this area, if you skeletize all this area, you can have this dilation because the pylorus is not functioning properly. So, you know, going to be avoiding a very important step of this procedure is, you know, to preserve the functioning, you know, because it's very important, not always preserving this innervation, but also to preserve a couple or 3 centimeters of antrum, because we are, you know, maintaining the propelling capacity of the antrum. And you're going to be avoiding this pylorus dilation that you mentioned. But anyway, it can happen. You know, we don't have, you know, absolutely, you know, you cannot avoid some issues. And in some patients, you can have some dilation of the pylorus. But, you know, it can be facilitate some dumping syndrome. We haven't seen dumping after SADIS. No way.
Wonderful point. Very important point that the innervation and the preservation of right gastric artery is important for a functional pylorus, and a functional pylorus will have better impact of pylorus preservation. Thank you so much, Dr. Torres, and for a wonderful presentation and being a part of MetaSearch 2021. Even though it's virtual, we feel we have seen you. Thank you for agreeing for this.
Absolutely. I hope to show you guys very soon face to face. You know, it's not the same, you know,
It's
to
not
have
the
our
same.
personal feeling and to have a drink and to have some comments, you know, it's a pity. But hopefully, you know, this pandemic will finish. I hope very soon, or sooner than later, and we'll see each other very soon. I hope so. Thank you.
Thank you. Thank you so much. Thank you, Ossi. Thank you, Ipso. Thank you, all my faculties, Mahendra, Randeep here, Amar. This was a wonderful brainstorming session and very different topics. I really enjoyed it, and it is a success only because of the support from all of you. Thank you, Dr. Torres. Be safe and be healthy. This conference will still remain live on YouTube. So those who have missed or those who want to listen to this discussion can still enjoy this. Thank you so much.
Thank you, Shashank. Thank you.
Bye-bye.
Thank you, everyone. All supporters, and we call it the end of MetaSearch 2021.
Thank you.
Thank you.
Thank you, Poonam, for joining us.
I always enjoy it.
Thank you. Now without mask also.
Yes, without mask. Thank you, Dr. Torres. Have a good day. Amar, thank you.
Randeep.